Age International, and I'm delighted to welcome you all to our Scaling Up Non-Communicable Diseases Interventions in Southeast Asia conference today. It's great to have so many of you with us online, and welcome to those here in person as well. We've got a fantastic lineup of speakers for what's going to be really rich and fascinating discussion. On behalf of Age International, I'd like to thank the European Union for their funding and all the SUNI-SEA partners and the Global Alliance of Chronic Diseases for their work on the project and for being with us today to share their reflections. As this is a hybrid event, for those online, we encourage your active engagement using the chat function of Zoom for comments and for questions. When it comes to time for question and answers, we'll select a few questions from the audience and invite those online to turn their camera on and to unmute to ask their question. For audience members attending in person, we'll also be looking for your questions and we'll get a microphone to you. There'll be 3 sections to the conference with a coffee break midway through. We're not expecting any fire drills, so if the fire alarm does sound, for those of us here, we need to follow the signs to exit the building. Everybody's encouraged to post messages on Twitter, and we're using the hashtags @NCDs and @UHC. As we want to be fair to all of our speakers, I'm going to have to be very strict with the timekeeping. I'll give each speaker a 2-minute warning, and then I will be strict about asking them to stop when their time is up. So speakers, please forgive me in advance. Without further ado, I'd like to invite Margaret B., Senior Impact and Policy Manager of the Global Alliance of Chronic Diseases, who's going to give us some context for our conference themes. Margaret is responsible for enhancing the Global Alliance's impact and fostering policy engagement. Previously, she worked as a health advisor for Concern Worldwide, supporting primary healthcare programs across Africa and Asia. And she also lived in northern Uganda, where she worked for MEDAIR in close partnership with the Ministry of Health to set up a community health worker program. Welcome, Margaret.
Thank you, Alison. Hello to everyone here in the room and also those online. Thank you for the kind introduction, Alison. As I thought about this topic, particularly around primary healthcare and the role of communities, I really thought back to my time in Uganda. I worked with the NGO MEDAIR, working with the Ministry of Health to set up a community health worker program. We trained volunteer village health workers to treat childhood illnesses and also refer complicated cases to primary healthcare facilities. So during this time, I was really privileged to live and work in the community in internally displaced people camps in northern Uganda and get to know some of these health workers and get to know the health system. And I just wanted to start by reflecting on that and saying, this is what we're talking about. We're talking about communities, we're talking about primary healthcare and access to services to communities who really struggle to access services a lot of the time. So today we're going to be particularly focusing on looking at NCD interventions and the role of communities and primary healthcare in achieving universal health coverage. So by way of introduction, for those who are not familiar with GACD, we are an alliance of 12 international health funding agencies who fund research that has the strongest potential to inform national and international policies around NCDs in low middle income countries. So the project that we're going to be hearing a lot more about today, SUNI-SEA, Scaling Up NCD Interventions in Southeast Asia, was funded by the European Union under the GACD Scale-Up grant. GACD is committed to improving health equity and reaching vulnerable populations. And primary healthcare and community engagement are key approaches that are used in many of our programs. Primary healthcare is the cornerstone of universal health coverage, and WHO recommends reorienting health systems to primary healthcare. They state that scaling up primary healthcare interventions across low middle income countries could save 60 million lives and increase average life expectancy by 3.7 years by 2030. With the UN high-level meeting on universal health coverage coming up later this year in September, the world's attention is on UHC. Universal health coverage means that all people have access to a full range of quality health services when they need them, where they need them, and without financial hardship. This full range of quality health services should include NCD prevention and control. And while lower middle income countries recognise the importance of addressing NCDs, and many have developed NCD strategic plans, health systems in these countries are often not able to cope with the increasing burden of NCDs and not necessarily able to implement and roll out these strategies. Evidence-based interventions for the prevention and management of NCDs exist already, and implementation research like SUNI-SEA explores how to implement these interventions in different contexts and how to ensure they can be adapted and scaled up in ways that are accessible and equitable. Implementation research provides context-specific evidence that policymakers can use to support their decision-making. We know that early engagement with policymakers and actively engaging them throughout the whole project cycle increases the likelihood that that evidence will inform policy. It provides opportunities for policymakers to shape the research and that the research can answer the questions that they're asking and provide the information that they need. The SUNI-SEA project is a strong example of stakeholder engagement, and I'm looking forward to hearing more from the team. They worked jointly with stakeholders to decide on the processes for scaling up. They also provided a number of policy briefs which could inform policymakers and provide recommendations and evidence. So I'm really looking forward to hearing more from the speakers today, from the SUNI-SEA project and all the range of different speakers that we've got. And I'm sure this is going to be a fascinating discussion. Thank you.
Thank you, Margaret. Now I'd like to invite Dr. Yap Coate, the SUNI-SEA project coordinator from the Department of Health Sciences at the University Medical Center, Groningen, to come and give the keynote address, which will give us an overview of the evidence from the SUNI-SEA project. Dr. Coate is a medical doctor specialized in public health and health management. He has experience in the Netherlands, in Central and Eastern Europe, and in middle and low-income countries all over the world. His research concentrates on policy development to reduce inequities in health, and in education, he focuses on global healthcare management and health promotion. Dr. Coate, welcome.
Thank you very much, and thank you for the very nice introduction, Margaret, about the background of SUNI-SEA, so that saves me already some minutes to explain. So we are indeed one of those projects on the scaling up of the GACD program funded by the European Union. And we have been working in 3 countries, in Vietnam, Myanmar, and Indonesia. And we have been working with universities here in Europe, but also in the countries where we have been working, and NGOs, and especially HelpAge International, that has been working in Vietnam and Myanmar. And our project was from January 2019 until June, so we are finishing this month. We got 4.5 year extension because of the COVID problems. So now the button is not working for next. Can somebody help me technically, because it's not working? what I'm supposed to do now, because sorry for the people online.
He's clicking the button.
Now it's working. Okay, sorry for this inconvenience. Now it's working again. So what we envisaged in our setup of the project is to have both a community and a primary healthcare component that would be working together, creating synergies where we would do health promotion and screening and lifestyle interventions in communities, combined with early diagnosis and medical treatment at the primary healthcare level, and getting an interaction between the two different components. Same problem again. So we have had different approaches in Vietnam and Myanmar with intergenerational self-help clubs that are more autonomous community groups that come with support from international organizations and national NGOs for more community development and focus on solidarity that added and improved the health component. While in Indonesia, we started with the Posbindu program, which is more an outreach program for community-based screening with volunteers. And what is important is that these two different approaches, we wanted to compare what would be working well and what would be more difficult in the two approaches. In our original planning, we first had a kind of what we call retrospective phase, where we would do an analysis of the local situation, international literature search to look at what are the best interventions to do, then followed by a baseline assessment on what is the actual state for the intervention areas with regards to NCDs, knowledge and attitudes and practices. Then we would have a phase for improving the scaling up with different interventions with a final analysis. However, as you all know, we had first the COVID problems that caused in our baseline assessment in that period already problems and delays. And we had a coup in Myanmar where we had to shift from working in the communities to more working online and shifting to safe areas where we would not have the problems with military government. So our intervention period was shortened. What we found in our retrospective phase is when we talk about scaling up, normally we hear about vertical scaling up, increasing the package of care, the horizontal scaling up, increasing the coverage to new populations and new areas. But what we found is that it is very important in existing programs to maintain the quality, because we did see in some areas where we were studying that when the quality goes down, then the effect of the program is becoming really very minor. So there are three dimensions in scaling up: increasing the package, doing more, increasing the coverage, reaching more people, and maintaining or improving quality. So what we looked at in our retrospective phase is what is needed for scaling up. And we found that it is necessary to work on the program, what is offered as a program. In the healthcare organization, how should the healthcare organization be able to implement that program? And of course, at the community, what are the demands and the possibilities of the communities? What are the different capabilities that are there in the communities? And what we found is that many of the NCD interventions are piecemeal, are salt control or physical activity or screening. But what we did see is that we need to have a comprehensive package that together will be able to improve NCD prevention and control. So let me go over a number of actions that we have prepared and carried out. First of all, community sensitization with health information, but also reaching people through social media and other means of communication to make them aware of what is being done. Strengthening of the ISHCs, so that is the community groups, and others will talk more in detail about what the ISHCs are and what kind of activities they perform. We also worked on strengthening patient groups, peer support for patients. And of course, what was very important was sharing results and making it visible for people, for the stakeholders with whom we are working, so that they would increase their commitment because of knowing what are the results and what is the impact of the work. And we also worked in Indonesia on Posbindu in the workplace on offering services where people are instead of requiring them to come to a place that's far from their work. And our team from Indonesia will explain about that later. So that's what we did in communities. In healthcare organizations, we did a lot of capacity building and training of cadres, volunteers, primary healthcare staff in a culturally adapted way. We looked at what are the best learning methods, the best ways to transfer knowledge and skills to people. We sometimes had to go for online training programs like in Myanmar, where it was very difficult to reach people, but also due to COVID, we had to experiment with online programs for training. We were engaged with the PHC organizations in resource mobilization, and I'll come back to that because that's appeared to be a very important part of being able to implement a program that the local people are able to mobilize resources locally. And we worked on commitment of decision makers, and I'll come back to that as well. Then with regard to the program as such, we looked at the screening protocols that were available in the different countries, and we improved them and worked a lot on having a screening program that could be carried out by volunteers in communities rather than healthcare professionals. We developed education materials as people needed to understand why they should come for screening and why it was important to adhere to treatment. We developed clinical guidelines, especially for primary healthcare level, because we noticed that many of the clinical guidelines are for hospital level. There's very few that are available for primary healthcare staff that normally has a lower level of education, so they need special training materials. We introduced electronic medical records at community level, but also at primary healthcare level to make a follow-up. And we also developed electronic reporting tools so that it would be able to measure impact of our activities. So you see a whole lot of different activities, not just one activity, not just in one area, but a comprehensive package that would help to get the program going. So we also worked on activities for scaling up the efforts, the work on getting a sustainable way of working. And we noticed that it was very important to engage with local authorities, local district, provincial authorities, because in the systems in the different countries, there is where many of the decisions are made with regard to community activities. And we see that national policies are important, but the ones who decide on where and what is being done are the local decision makers, sometimes local government, where the social sector is under local government, sometimes local health authorities. So scaling up, I will come back to that, starts really with the local authorities and local people. And of course, as Margaret mentioned, both Vietnam and Indonesia, but also in Myanmar, there are policies and strategies, but actually to get them implemented still requires a lot of advocacy to make it happen. And we will hear from our partners on their experiences. And also Help-Age International helped us to spread their message. They are a very big international organization. So now also in Africa and Latin America, they are using our tools in different ways. We conducted, of course, research. This was a research project. So we had a baseline and an endline survey where we looked at community groups that we interviewed at the beginning and after some period in time, with different questionnaires for quality of life, knowledge, practice, attitudes, health-seeking behavior, to see what has changed over time. And we did many different smaller research activities like evaluation of training programs, satisfaction surveys among users, the functioning of ISHCs. We looked at how innovative post-Bindu activities were implemented. We looked at digitalization, what are the pros and the cons, and of course the scaling up process. Many of these publications are still on the way, but we have already some 10 publications internationally on the research that we conducted. Now, what is important, of course, you want to know what have we achieved. And I realized that one slide probably was skipped. Awareness in many low and middle income countries about diabetes, cardiovascular diseases, and NCDs is very low. Many people don't know what these NCDs are, what are the risk factors, and how they contribute to these chronic diseases. What we were able to achieve in both Vietnam and Indonesia, because in Myanmar we couldn't do this endline survey, that there's a significant increase in awareness and knowledge in the people where we did intervention. So we compared the intervention group with the control group, and there's a significant increase in knowledge and awareness. So the health education material, the sensitization, the messages have reached the people. What we also did see is that there is more awareness and more attitudes to improve behavior and change. And in Vietnam, we really found evidence that people have changed their behavior with regard to physical activity, diet, and alcohol intake. In Indonesia, we didn't see a significant increase, but we did see a slight increase in attitudes, but the period for intervention was very short. So at least the positive is that attitudes are changing as well there. In screening, we found both in Indonesia and Vietnam that around 30% of the people that we screened have hypertension. And of course, they were referred to primary healthcare for further diagnosis and treatment, but that's a high number of people have unknown hypertension. And the same for diabetes. We used the FINT risk score, and that's an international score that has been tried out also in low and middle income countries. And we found that around 5% of the people have very high risk for diabetes, so they need further diagnosis and treatment in primary healthcare. And so you see that in our program, we are discovering a lot of undiscovered NCDs that really need to be addressed. That is what we did in primary healthcare with, of course, the local teams. And what we did see in Vietnam is that due to the training of health workers, especially in counseling and explaining to patients, that we achieved a better adherence to treatment. So despite all the problems with COVID and the short intervention period, we did see improvements across the board in both community interventions and in primary healthcare interventions. What were now the contributing factors? First of all, it's important to work in co-creation and co-ownership and increase access and also make sure that there is frequent supervision, that the quality assurance is guaranteed. In barriers that time constraints and not sufficient support to volunteers are problematic, as well as turnover of staff. What are the costs of this? We also did a cost effectiveness analysis. And for setting up the improved ISHCs with a health component was around $45 per member, with $34 per person for screening and around $200 per diagnosed NCDs. So those were the costs that we were having in our project. And of course, when you reach an economy of scale, these costs will go down. But that's what it would take to have this community program spread out. The costs when you diagnose diabetes and hypertension, of course, will increase for the healthcare services. And that will be per ISHC, as we calculated it, around $35,000. That's a lot of money. There's huge investment needed if we really want to tackle NCDs. But if we do nothing, and the costs of complications and healthcare and people diagnosing in an advanced stage are like 46,000. So still we can save a lot of money by doing early interventions and early diagnosis and preventing people getting ICDs. But we need to work in a coherent way. In the scaling up, it's very important that we look, as I said, at the local circumstances with devolved governance where local people decide on the resources available. But on the other hand, make sure that the quality assurance, as I mentioned at the beginning, is coming from top to down, and at every level, quality is assured. So we need to invest much more in NCD prevention and control. We need, GACD is doing some research, but we really need a kind of global fund for implementation worldwide, because we spend still a lot of money on TB, malaria, and HIV, but NCDs are the major killer worldwide. So we need to really invest in NCDs in order to improve health of the population. And our project shows that we can invest in early detection, in health promotion, and can do it at community and PHC level, that we don't have to wait until people have complications and go to a hospital. We can do it at the community and primary healthcare level. This is cost effective and helps us to maintain a cheap health services, relatively cheap, because we need to invest in NCDs, that's for sure. But the combination of community health work and PHC work is really going to be an advantage for better health for the people. So thank you for your attention, and I hope that we get more insights from other members of our consortium who will go in more detail in different aspects that I mentioned. Thank you very much.
Sau khi sàng lọc ở câu lạc bộ là tôi tham gia câu lạc bộ, thấy bổ ích, và câu lạc bộ sẽ biết được bệnh của mình là nguy cơ là cao huyết áp. Vậy là câu lạc bộ giới thiệu tôi sang trạm y tế để khám lại.
Selain pelatihan itu juga ada bimbingan, ya pendampingan dari tim-tim SUNI-SEA, baik kader maupun dari kita juga selaku petugas dari PTM. Jadi kolaborasinya sudah cukup baik, tinggal menerapkannya kita dalam penyakit tidak menular.
ကျန်းမာရေးဘုဒ္ဓတာအရင်အားနေတယ်ဒီ SUNI-SEA application နဲ့သူတို့ကိုသူတို့လည်းဆန်းစစ်နိုင်တယ်နောက်ပြီးတော့မှကျန်းမာရေးဘုဒ္ဓတာတွေလည်းတိုးလာတယ်ပေါ့နော်အဲ့လိုမျိုးအကျိုးကျေးဇူးတွေရှိရလို့တော့
Sau khi tham gia dự án thì tôi rất là những có cái kiến thức rất là bổ ích và hai cái bệnh là cao huyết áp và đái tháo đường. Thứ nhất là biết được các cái triệu chứng và biết được cái nguyên nhân và biết được cái cách phòng ngừa của bệnh, có học được kỹ năng là sau khi làm sàng lọc thì trước hết là cái tình nguyện viên của chúng tôi là chúng tôi sẽ cân để biết được cân nặng, đo thì là biết được chiều cao và đo huyết áp và cái bảng chấm điểm để biết được là nguy cơ của cái bệnh đái tháo đường là chúng tôi tư vấn và cho các thành viên đến trạm y tế để sàng lọc và cho trạm y tế để là khám và để sàng lọc xem là có đúng để là bệnh nhân để chữa. Cái dự án là rất là bổ ích để cho câu lạc bộ chúng tôi cũng như bản thân tôi là thay đổi được các cách cái lối sống và các hành vi rất là thoải mái và có cuộc sống rất là lành mạnh.
အဲ့ဒါပြီးတော့ကျွန်တော်တို့ data မှာဆေးရုံဆေးခန်းတွေဝေးတဲ့နေရာမှာအခက်အခဲတွေကျန်းမာရေးအခက်အခဲတွေအများကြီးတွေးကြုံနေရတဲ့အတွက်ကျွန်တော်ဟုတ်ကဲ့ဒီ SUNI-SEA စီမံကိန်းကျေးဇူးကြောင့်ကျွန်တော်တို့ရွှေတလူအဖွဲ့နဲ့ဒီကျေးရွာမှာရှိတဲ့ပင်းတရမြို့နယ်တွင်းမှာရှိတဲ့ကျေးရွာ56ရွာမှာရှိတဲ့ဒီပြည်သူလူထုတွေကိုဒီကျန်းမာရေးနဲ့ပတ်သက်တဲ့အသိပညာတွေကျွန်တော်တို့ရရှိခဲ့ပါတယ်
Pospindunya kebetulan saya di situ bertugas sebagai pengecek gula darah. Kayak gitu. Dulu saya itu tidak pernah tahu bagaimana cara pengecekan gula darah, kolesterol, asam urat saya itu nggak pernah tahu. Tapi setelah adanya pelatihan di Gayeng dari SUNI-SEA, kita jadi tahu gimana cara mengukur lingkar perut, tinggi badan, kayak gitu, serta pengecekan gula darah, asam urat dan kolesterol.
Vâng, tôi thấy là cái dự án này là 688 này là rất là thiết thực. Thành viên trong câu lạc bộ cũng đã hiểu được hai cái bệnh lây nhiễm này mà để mà phòng ngừa rồi thì là ăn uống sinh hoạt để cho nó lành mạnh để tránh được hai cái bệnh này.
ဒီ application ကိုအသုံးပြုပြီးတော့မှကျွန်မအနေနဲ့အကျိုးကျေးဇူးတွေကအများကြီးရရှိပါတယ်ဘယ်လိုအကျိုးကျေးဇူးတွေလဲဆိုလို့ရှိရင်ဒီ application ထဲမှာပါတဲ့အကြံပေးချက်အတိုင်းပေါ့နော် application ပေးတဲ့အကြံအညာအတိုင်းလိုက်နာနေပါတယ်ဥပမာ lunch water တို့အစားတွေအငံတွေဆော်စားတာမျိုးပေါ့နော်အချိုတွေဆော်စားတာမျိုး
Saya pribadi mendapatkan suatu dampak yang bagus dari program SUNI-SEA ini, di mana boleh kami gambarkan kelompok kader yang mendapatkan pelatihan dari SUNI-SEA ini ada perubahan giat, perubahan semangat dalam melaksanakan Pospindu.
Và sau khi dự án kết thúc thì Sở Y tế sẽ tiếp tục triển khai các mô hình điểm về các câu lạc bộ liên thế hệ tự giúp nhau. 25 câu lạc bộ liên thế hệ tự giúp nhau đã được triển khai này thì nó là điểm để chúng tôi tiếp tục nhân lên mô hình câu lạc bộ này trên toàn tỉnh.
Wow, that was great to hear the voices of all of those involved. And just a reminder for those of you online, do use the chat to comment and ask questions. And then when it comes to the question and answer session, we'll invite those whose question we want to hear to unmute. So we now move into session 1, which is building genuine synergy between people and communities and primary healthcare for improved NCD services. This session will focus on why and how linking communities and primary healthcare is essential for effective NCD interventions and how that should shape a bottom-up approach to policy and system development. We're going to hear from government, NGO and research partners, as well as getting a global perspective from the World Health Organization's Global Coordination Mechanism on NCDs. First, we're going to hear about the links between intergenerational self-help clubs and primary healthcare for NCD and healthy aging in Vietnam. We have two speakers, Chan Bích Duy and Dr. Chan Thi Mai Wang. They're each going to speak for 10 minutes. I'd like to introduce them both. So, Duy is the country director of HelpAge International in Vietnam. She has over 20 years experience in development, with 16 years working on aging. She's one of the founders of the intergenerational self-help club model, which promotes healthy aging and active aging in Vietnam using a community-driven approach. And thanks to her contributions, Duy was recognized as one of the healthy aging 50 leaders transforming the world to be a better place to grow older by the UN Decade of Healthy Aging. Dr. Wang became director of the Vietnam Health Strategy and Policy Institute in 2013. That's part of the Ministry of Health in Vietnam. And she's been responsible for conducting research to provide evidence and technical consultation for health policy making in Vietnam, participating in regulation, formulating and addressing the impacts of health policy implementation. And she's a member of several national committees on health policy development. She has worked extensively with policymakers. I can't wait to hear from them both. I'd like to invite Duy to speak first, please.
Thank you very much. Thank you for the opportunity for me and Dr. Wang to present about our synergy approach between the community-based organization and the primary health care in Vietnam in tackling NCDs and achieving UHC. In the next 20 minutes, I will present about the intergenerational self-help clubs, and Dr. Wang will present the 3 remaining parts. Next slide, please. Next slide. So why in Vietnam we invest into the intergenerational self-help clubs? So as you know that Vietnam is one of the countries having the fastest population aging speed in the world. It takes us only 20 to 25 years to transit from the aging society to an aged society. So we have very little time to prepare for an aged society. However, we are still the lower middle income countries and we have very limited resources to properly respond to the rapid aging. You can see here that still we have 13% of the older people live in the poor or near poor household. And more than half of the older people in Vietnam do not have any form of pensions. And almost 95% of the older people in Vietnam have NCD. However, they have very low awareness on NCD and also lack of health promotion and limited access to the health services. The life expectancy in Vietnam of Vietnamese people is really high. It's nearly 74. However, our healthy life expectancy is just 64 years, meaning that the number of years that the Vietnamese people living with the diseases is still long. So in the context that we are getting old before we are getting rich, investing and promoting the healthy and active aging through the intergenerational self-help clubs, a community-based model, is the best option for Vietnam. Next slide. So what is the intergenerational self-help clubs, or in short, is the ISSC in Vietnam? It is the voluntary and social organization consisting of 50 to 70 members. The club is established at the very grassroots village level and is supported and overall managed by the Association of the Elderly. This Association of the Elderly is a people's organization representing the interest and the right of older people in Vietnam. The purpose of the ISSC is to improve the well-being of their members. Majority of the members are older people, women, and other vulnerable groups. And the club focus on the number of the areas, including health and care, income and social participation, lifelong learning, and voice. Next. And the club is managed by the management board consisting of 5 members. So 50 to 70 members are divided into the different neighborhood groups for easy management and implementation of the activities. Each group around 10 members. And each group, they have the group leaders to manage and to promote the peer learning. So under the SUNI-SEA project, the group leaders are also the healthcare volunteers to promote the peer learning and also the peer support. Within the club, there are different interest groups like a social and cultural groups, a physical exercise and sport group, home care volunteer groups, livelihood groups, and many others. So this is the beauty of the ISSC that help them to be attractive to everyone. Next. So a typical ISSC has at least 8 core areas of activities that enable the model to respond better to their needs of their community members. So the club covers social and cultural bonding, food and income security, resource mobilization, community-based care, community development, lifelong learning, right entitlement, and healthcare. And in order for them to implement all of these 8 core areas of activities, they conduct the monthly get-together or meetings and many activities during the month. Next. Now we will look at the more detail into the healthcare activities of the ISSC. So you can see here that the club promote regular physical exercise and sport. They also organize a monthly health screening so that they can measure the weight and the height and the blood pressure regularly to identify the risk. They also promote self-care through providing health and care awareness section during their monthly meetings. And in collaboration with the health sector, they also organize 6-month health checkup. In addition, they also promote the health insurance. You know that in Vietnam, not all older people have health insurance cards. Still 5% do not have. And finally, but very important, they also provide a reference. So they refer those who have the high risk of NCD to the primary health facilities for early diagnosis and treatment. Next. Over the years, the ISSC is proved to be very relevant and effective model that promotes the healthy aging, and is also addressed the social determinants of health through variety of the activities, as you see. Next. This is the evidence that show that the ISSC can bring great benefits for their community members. Through our survey in a number of projects, over more than 8,000 members, you can see that most of the members reported that they feel happier, they feel healthier, wealthier, more empowered, and more confident. And this is why in Vietnam, the government really support the ISSC. Next. Because of this great benefit, so the ISSC is really attractive and sustainable. First, because it can attract and maintain their members. And second, it is designed to be financially sustainable. Third, it is also technically sustainable through the number of capacity building activities. And very important, it is owned by the people, by the community, association of the elderly, and the local government. And very good that recently the ISSC is already promoted by the government through the number of the national program to promote the ISSC, as well as to promote the healthcare for older people through the ISSC. And under the SUNI-SEA project, we are happy to see the systematic collaboration between the Association of the Elderly, the ISSC, and the health sector. However, it is just only under the SUNI-SEA project site in 2 provinces. And by the end of the project, HelpAge, we start to replicate this model into other ISSC replication projects, such as the World Bank GFDF funded project or the COICA funded project, so that we can scale up this approach into the other ISSC. However, the number of ISSC in the country is very huge, and we hope that in the future, in the coming years, there will be more systematic collaboration between the ISSC, Association of the Elderly, and the health sector in healthcare for older people, especially in the NCD management and control. Next. We are also very happy to see the very rapid increased number of the ISSC in the countries. In 2006, it is only 60 ISSC. However, currently it is already 6,000, and it is expected that by 2030 it will be 10,000 ISSC all over the country. So in conclusion, ISSC is the very relevant, comprehensive, and sustainable community-based model in the country. And to tackle NCD and achieve USC effectively, it is very wise to invest into ISSC and also in the collaboration between the ISSC and the health sector. Thank you very much. This is the end of my presentation. And now Ms. Oanh, Dr. Oanh will continue the presentation. Thank you.
That was fantastic. Dr. Wang, over to you.
Can you hear me? Hello?
Yes, yes.
Can you hear me?
Yes.
Okay. Okay. So following presentation from Mrs. Thuy, I would like to share with you more information related from the perspective of health, because Mrs. Thuy introduced about the availability and the development of ISSC related to the elderly in the community. And then for myself, I want to share more information on the perspective from the perspective of health. And in these slides, I think a similarity to other countries in the world, we also have to face with the problem of the high burdens of NCD. And in Vietnam, the NCD account for about 2/3 of the total national burden of disease. And among those cases of death, the cardiovascular disease account for about 40% of the NCD death. And hypertension is the major disease of cardiovascular disease. However, we have to face with the problem that the problem in terms of the delay in access to healthcare among the hypertensive patients. Like in the figure, you can see that about 2/3 of the hypertensive patients cannot access to healthcare. I mean, they can access to healthcare, but the completed treatment, it is not 100% of providing treatment, and also high percentage of hypertensive patients they are not control of their high blood pressure. So regarding when looking at on the pupil healthcare needs, we can see that about 80% of pupils they are having the mild illness, or they are healthy pupils. So these 80% of pupils, they can be taken care of at the grassroots level by the grassroots health facility. So we can see that the grassroots health facility plays very important role in providing primary healthcare services for the patient in general, and especially for the hypertensive patients. Regarding to the role of communication in NCD prevention and control, in this slide, maybe it will be clearer for you to see the role of communications. It is not only the first lines of treatment for hypertensive patients, but they're also responsible for screening, for early diagnosis of the patients, for those who amount to the high-risk pupils, and also the grassroots health facility also provide the health preventions and health promotion activities for the healthy pupil. And according to the healthcare needs at the moment, we can see the higher needs of transforming the healthcare system, and in which it should shifting from the hospital care to the primary healthcare oriented with a multi-sectorial engagement and community empowerment, so that it can promote the participations of people in the communities in having the self-care and their disease management. And also the health system should be, the health service delivery should be shifted from the passive care to the proactive and proactive care for the people in the community. In Vietnam, in order to address this, the problem of changing the mobility pattern, the government issue several policies to strengthen the healthcare for the people in general, and specifically focusing on the strengthening the NCD prevention and control for Vietnamese people. So the policy is issued at different levels. At the highest level, it is issued from the central party with the directive issued from the central party, in which they also have the concrete target focusing on the NCD treatment and management at the grassroots levels. And also in this directive of the central party, they also highlight the community engagement in health program. At the government levels, we did already develop the government strategy on NCDs and population aging, in which for the national strategy on NCD preventions, we also mention, and not only mention, but also highlight the requirement of NCD management at primary healthcare levels, and also promote the applications of community-based NCD models in the communities. Another thing, another thing is that on the national program on action of aging, it also put the target of for the established of the IHSC models, like what Dr. Thuy already mentioned. So we can see that in some house we can see in terms of the policy, it points out the role of IHSC and also the role of grassroots healthcare facility. So the important thing is that we should have the connection and the linkage between the IHSCs in the communities with the primary healthcare networks in the countries. So with the SUNI-SEA project, we see the higher needs of having the connection between the community and primary healthcare facilities. So SUNI-SEA is designed in filling the gaps between the performance of IHSCs in the communities and primary healthcare performance. There is activities to put the linkage, to promote the linkage between these two organizations. So in order to implement this project, the SUNI-SEA intervention in Vietnam framework, we have the 4 components. The first component is focusing on the local health authorities, because we are aware that with the commitment from the local authorities, we will have the concrete guidance and directions for better intersectorial collaboration and better engagement of the community within with the health sector. So the first component is the local health authorities. The second component is the improving capacity of the healthcare providers with the aims of providing better quality of services, better quality of the screening for the NCD patients, And the third component is focusing on the community, strengthening the community engagement and actions, focusing on the activities of the IHSC and their members, like what Dr. Thuy presents previously. And the fourth component, focusing on at the individual patient levels, where we provide the knowledge and skill for the patients so that they know how to do better self-management of their disease. Yes, and in this project, we implement and we promote the continuous collaboration and stakeholder engagement in the communities. So this is some picture showing how we work with the community leaders and with the social organizations, as well as IHSC, together with the primary healthcare facilities activities. So we would like to say that we have a comprehensive intervention package across intervention groups. As I mentioned, focusing on the IHSCs, focusing on the primary healthcare facilities, and focusing on the patients. And we implement activity to build capacity, to strengthen the capacity of IHSCs, as well as the capacity of the healthcare providers at the grassroots level, and also improve the capacity of the patient in terms of having better knowledge and skill in managing their health. And in this project, we have 3 dimensions scaling up outcomes. The first dimension is that focusing on the increasing screening service delivery. So the aim is to have more collaboration between the IHSCs and the community health stations in implementing the screening activities, and also provide regular treatment for the patient with hypertension. And also we collaborate with the Association of the Elderly in improving the collaboration in terms of helping the pupil to participate in the health activities in the communities. So the second dimension, it is focusing on the quality, increased service quality. We hope that, and we expect that we will have to have a better knowledge and skill of the IHSC health volunteer, as well as the primary healthcare staff, and also the knowledge of the patient as well. And the third dimension, focusing on the coverage, reaching more people, where we expect to increase the IHSC's members attending the health education trainings, as well as participating on the screening activities, and how can I say, the compliance with the treatments of these hypertension disease for the patients. And also in this project, we expect that the high-risk people also refer from the IHSC to primary health facility for further diagnosis and treatment. So the last slide, I think, yeah, this is the last slide. It is on the SUNI-SEA lesson learned. We see that the communities-based groups and pupil organization, here is the Association of the Elderly, can be effective, extended. It can be considered as the extended arms of the primary healthcare health workforce, because they are living in the community and they have a good connection with the people in the communities. So they can help the primary healthcare health facility to bring the services in terms of the health prevention and health promotion activities to the hard to reach patients in the communities. So the key to success, we point out, we draw the 3 key factors for the success. The first one is that the policy, the availability of the policy context. It can support for the scaling up of our intervention, because the policy already exists. So our intervention, and also when we scaling up, it will support for the implementation of the policies. The second factor for the success is that we have nationwide widely network of community health stations and association of the elderly, and ongoing national scaling up of ISSCs, where we will improve the number of ISSCs. Another factor is that the existing political and administrative arrangement of health sector and elderly association at all levels. So how we should move forward?
I'm going to have to ask you to finish there. I'm very sorry, but we need to be moving along. I'm really grateful for your excellent presentation. Thank you so much.
Yeah, okay, thank you.
We need to move to our next speakers, but let's have a round of applause. Thank you very much again to Thuy and to Dr. Wang for their excellent presentation. Now we're moving on to hear about increasing community engagement in NCD screening in the midst of primary healthcare transformation in Indonesia. We're going to hear from Dr. Maria Endang Sumiwi, Director General of Public Health, the Ministry of Health, Indonesia, and from Dr. Ari Probandari from the Universitas 11 Maret in Indonesia. Dr. Maria has been working in the position of Director General of Public Health in the Ministry of Health of Indonesia since March 22. She began her career in a non-profit, Médecins Sans Frontières Belgium, and prior to joining the Ministry of Health, Dr. Maria spent nearly 8 years as health specialist with UNICEF. Dr. Ari is a medical doctor with specific training and expertise in public health. She focuses on implementation research of disease control programs, program evaluation, and health systems. Dr. Ari currently serves as head of public health doctoral study program in the Faculty of Medicine at the university. Welcome to you both. We look forward to hearing your presentations. You have 10 minutes each. Thank you.
Thank you very much. Good morning, good afternoon, everyone. Thank you for the invitation. From Indonesia, I would like to share the topic that was requested, increasing community engagement in NCD screening in the midst of primary healthcare transformation in Indonesia. Similar with other countries, our epidemiological profile of our population shifts to NCD as the largest burden of our disease burden in the country. Comparing in the last 10 years, we see the shift from communicable disease to non-communicable diseases, and 4 diseases currently cause the greatest financing burden to our single payment country health insurance. Cardiovascular diseases, cancer, stroke, and kidney failure actually are the 4 highest burden of disease that take our health financing proportion quite highly. This is because all of these diseases actually ended up in the hospital with higher costs, but also with worse quality of life for the patient. Post-pandemic, we are actually embarking in a quite ambitious health transformation with 6 pillars of health transformation, from primary healthcare, secondary care, health system resilience, health financing, health workforce, and health technology. So one of the very important pillar is primary healthcare transformation, of which our Directorate General is being responsible for to bring forward the primary healthcare transformation agenda. So the primary healthcare transformation have 4 areas to improve. One is the population education, second is primary prevention, the third one is secondary prevention, and the last one is improving capacity and capability of the primary care. This is include the strengthening the network of the primary care and ensuring that our primary care system actually reach everyone in the country. We are a very big country with 270 million people, so it's not easy to reach everyone, especially if we want to shift towards promotion and prevention, because it means that we have to reach everyone. With curative, I think our infrastructure at the moment probably could reach majority of the people, but for promotive and preventive, we cannot rely on our primary healthcare as such. Now we are going to strengthen this network. The initiative to strengthen the intervention first, what we are doing is we add routine immunization that is funded by the government from 11 to 14 types of antigen. This is for non-communicable disease, the cervical cancer. We just added HPV to our routine program, but also PCV and rotavirus. This is for children. The second one, what we are now strengthening is the early detection through screening. So we put in place 14 screenings to be conducted in the primary healthcare so that we can detect the NCD, especially, mostly NCD, in a very early stage of the disease. So it can be managed more cheaper, but also better quality of life of the population. The last one is improving maternal and child health. We have just put also ultrasound in our primary healthcare for better monitoring of the antenatal care, but also for screening of breast cancer. The transformation that I have just told you on the primary healthcare is containing mainly 3 transformations. The first one is shifting focus towards life cycle-based integrated primary healthcare, meaning we focus on the person that we serve, which package of service that they need. So we are not anymore working on a programmatic base, like malaria program, tuberculosis program, HIV program in our primary healthcare, but we are making a standardized package service for every life cycle. The second one is to bring health services closer through care networks, to the village, to the hamlet, but also through school and workplace, because we want to reach everyone with promotion and prevention effort. And the last one is to strengthen the local area monitoring. I will talk more about this later. This is the network that we are now embarking to strengthen. Usually we stop at the puskesmas level, but puskesmas is at the sub-district level, but now we want to work better through community health worker, and the posyandu is at the sub-village level, including at the village level. So this is the whole network that we are now working on to strengthen all together, because otherwise when we work just at piecemeal, then we will never really have a very good system strengthening. The way it works is at 3 levels. One is at the sub-district, at the village, and at the sub-village. This is the flow that we arrange to have the patient being served at every level, but also that the primary healthcare center at the sub-district level actually communicate very well with the village, but also with the community health worker at the hamlet level, using the digital transformation of data system in the primary healthcare and the local area monitoring with dashboard that can show health status at the village level, including the coverage of intervention at the village level. So the data will be the blood of the system that move everyone to work, actually. So this is the standard service that we have just established for every life cycle. So pregnant mothers, babies under 5, and then school-age children, elderly, and also adult and elderly. Most of the adult and elderly package are actually screening. I think, yeah, usia produktif dan lansia is adult and elderly. So we put a lot of screenings in our primary healthcare. In the heart of this transformation is the village unit. This is where actually people can reach the facility better, is at the village level. So at the village level, we add community empowerment. Before it's just a health worker there. But now we add at the pustu level or at the village level, we add 2 community health workers so that they can discuss what is happening in the village, including what they found during their home visit to the families, so that they can evaluate the situation at the district and actually act on it. So the other network is school, because we have 70 school-age children. So we also, the primary healthcare will also work through school health and also through the workplace, because we know that our conventional system with primary healthcare and the village level service cannot reach those that are working and those that are in school. So we put also health in the workplace, where we will use also the package that we put in the primary healthcare can be also used for those in the workplace, especially the early detection or the screening, because we have 144 million workers, but this is including informal workers in the workplace. The last one that I would like to share with you is the community health worker strengthening. Usually we have this as a voluntarily based community health workers without really standardized competency or skills and the training system or capacity building system. We are now starting to put in place the skills set that has to be acquired by the community health workers, from pregnant mothers to babies to through elderly. So our activities in the village will cover all life cycle with community health workers that can deliver also this intervention package. So we have piloted this in the 9 areas in the country, from the west to the east, from the urban, remote, very remote areas, with quite very actually promising result. We see increase in visit to the facilities at every level, but not only sick visit, but also healthy visit, meaning those that is not showing symptom, but to be screened in this facility. So we have a lot of increase in visit, and we have just introduced home visit by community health workers to identify 3 things, which is missing service, non-compliance, and danger sign. So in relation to the non-communicable diseases, missing service meaning to check if the people at the age group that we our target population knows their hypertension status or their diabetic mellitus status, and we know from the home visit that most of our people doesn't know their hypertension status and diabetic mellitus status. The second one is to
I'm really
identify.
sorry, but we need to move on now to Dr. Ari.
Okay.
Thank you for your excellent presentation.
Thank you
so much.
Yeah.
It's been really fascinating. A round of applause for Dr. Maria. Thank you. Dr. Ari, over to you.
Thank you very much. Let me also continue with the presentation about what we are doing in the SUNI-SEA project in Indonesia. So I would like to put 3 highlights points here. I would like in a brief talk about the activities of SUNI-SEA project in Indonesia, the results and recommendations. We are in Indonesia working particularly in the 4 districts. So that consists of 2 districts for intervention and 2 for the control area. That's Surakarta city as a control area, as well as for Jember Regency, that's in the both Central and East Java province. And we particularly working with Batang Regency and Kediri city as the intervention area. So Dr. Yap should already mention the phases of the SUNI-SEA project. We initiated with the retrospective phase, which is the data collection, try to explore the situations, the context for more analysis. So during that period, we found actually that the NCD screening activity in the post-BINDU having like a lacking of participation, particularly from men and from younger people. The post-Bindu activity actually is designed for screening NCD for the productive age people. But our situation analysis found that almost 80% of the participants of post-Bindu were women and adult over 50 years old. That's half of the participants. So it showed the suboptimal coverage of men and younger adults. And we also identified lack of resources and limited time to perform the complexity of the activities and reporting. And then based on that result from the situation analysis, we designed some interventions like a package, what Dr. Yapshut already mentioned, a package that include the implementation of workplace post-Bindu, or we also call it institutional post-Bindu, and simplified algorithm of post-Bindu, as well as form and training the cadre for linkage to care. The training also involved the primary healthcare staff to have good coordination with the cadres. So the three types of this intervention address the particular barriers that we found in the situation analysis. We categorized that into some activities related to the identification of population at risk, screening, and diagnosis and treatment. So after the intervention for about 1 year, even though that's in very short period of intervention, I can say, but we can show there is a improve of participation of younger male in the workplace post-Bindu. You can see here in the graph. So we can see increase of proportion of male participations in the institutional post-Bindu compared in the general post-Bindu in the community. And in the qualitative exploration, we also found that actually the benefit of having institutional post-Bindu, it's closer to the work of the participants, so they doesn't take time to go back and forth from home to work. It's more efficient. That's the statement of one of the participants of the institutional post-Bindu. And also they have to have benefit to have early detection of the problem, for instance, for the high blood pressure. For the second category of our intervention, which is related to the screening, we particularly applied simplified algorithm and training that's used by the cadre. So our intervention was revealed improvement of the cadre skill and knowledge, and also the participant satisfaction of the post-Bindu in the community. And we also show the improvement in skill of knowledge after the training. But of course, we also identified that there is a need for refresher training in addition to the initial training for the cadre. So you can see in the illustration from the graph. The qualitative also showed that the cadres perceive more knowledgeable about the post-Bindu activities and know more about non-communicable diseases, and the flexibility about the simplified algorithm make them be able to adapt if there is a lacking of a number of cadre in the post-Bindu, because they can use that algorithm by moving instead of 5 tables into only 1 table, but they do all the activities in 5 tables. For the third category of the intervention, which is related to the diagnosis and treatment, this is what we call it linkage to care. I think this is something that we still to be worked more, because of a very short intervention period. But here, what we can show is actually we can find high proportion of people that were identified as having risk factor on or NCD based on our intervention, even though there is still low proportion of people that revert. So this is the illustrations about the reason of non-referral. So here we learn actually that we should include also the other part of the stakeholder, which is the private provider, for instance, in the linkage to care concept. And also the knowledge and also awareness of community in regard to the hypertension or diabetes is also something that's still to be built on, because one of the barriers of the community to be referred to the health facility, even though they have the risk factor, is having no complaints or perceive no health matters. And also the barrier in regard to the access to primary health care. For instance, is one of the statement of the post-bindu participants that perceive that the primary health care is far away from the home and they prefer to go to the midwife or just buy medicine in the pharmacy. This is something that we learn more from the findings, that in advance, the SUNI-SEA intervention should be also developed more to engage the other providers. So finally, in the midst of the primary healthcare transformation that Dr. Maria already mentioned, we recommend some policy recommendations here. For instance, about the investment of post-bindu capacity, resources, and linkage of the reporting system. That's something that actually in harmony with the transformation that Dr. Maria mentions, which is the standard of service in the primary care. And the second one, the implementation of the synergy approach in the SUNI-SEA should be continued to ensure the mechanism and resources that are supportive. That include also financial mechanism. This is something that should be more advocated in the village level. The third one is about the continuous capacity building for volunteers and primary healthcare staff. That's related to the model of linkage to care that SUNI-SEA project already initiated. Continuation of the capacity building will develop that model more and can be advantage for the current primary healthcare transformations. And the last one, we also promote that the NCD screening as well as linked to cares in the community that's feasible and sustainable. And I think this is something in synergy also with transformations that Dr. Maria and them already highlighted. And we provide all tools, guidelines that can be beneficial as well for the current transformation. So really hope that the Ministry of Health can take the advantage of the available products of tools and models that we provide in the SUNI-SEA project into account in the strengthening of health system in Indonesia. Thank you very much.
Thank you, Dr. Ari. Thank you again, Dr. Maria. That was excellent to hear from Indonesia. And now I call on Maya Olsen to give us a global perspective on effective synergies between people, communities, and primary healthcare for improved NCD services. So Maya is Technical and Implementation Consultant, WHO Global Coordination Mechanism on NCDs. She provides technical support to the lived experience workstream of the WHO Global Coordination Mechanism on the prevention and control of NCDs, including activities around implementation of the WHO framework for meaningful engagement of people living with NCDs, mental health and neurological conditions. She was previously advocacy lead for Partners in Health. Maya, welcome. Over to you.
Thank you so much, and thank you to all of the organizers for including our team and our work in this conference. And it's been really wonderful to learn from some of the other panelists this morning. And I'm also representing our unit head, Dr. Guy Phones, and all of his leadership in this space in this conference. So I was going to start really briefly with just an introduction to the Global Coordination Mechanism for those that are less familiar with our work at WHO, and then really dive into some of the work that we're doing in meaningful engagement with people living with NCDs and mental health conditions kind of across the world. I, for a long time, was on the civil society end of this. I've been a long time lived experience advocate. I am a cancer survivor and someone living with a severe immune deficiency disorder, and had been working in a lot of capacity building work around working with advocates, African continent, as well as countries like Nepal, around meaningful engagement. And so it's been a real honor to be able to continue to work with WHO in this broader capacity across regions. And really looking forward to the conversation around that later in this session. So in terms of our work, again, just very briefly, the WHO Global Coordination Mechanism is a technical unit within WHO. We are focusing on promoting and enabling collaborative responses to accelerating progress in NCDs, strengthening national capacity and leadership, governance, and really sort of multi-sectoral action and collaboration, and really thinking about effective and inclusive policies, programs, and services. And so we have supported the development of guidance and tools, as well as serving as this mechanism to connect stakeholders, kind of multi-sectoral action around NCDs. There we go. So we focus on a couple of different priority areas, one of which is knowledge collaboration, and really trying to be a hub and facilitating the co-creation and dissemination of evidence-informed approaches among member states and non-state actors. And I hope to show you a little bit more about our knowledge action portal on NCDs at the end of this presentation, which has been a community-driven portal for much of that work. We also are working with member states on assessing and documenting multi-sectoral collaboration for NCD prevention and control, and have done various efforts around global mapping and case studies to really understand successful initiatives within this space. A lot of our work has been engaging with non-state actors and kind of in all of the WHO geographic regions, providing guidance to member states on how to engage with non-state actors, as well as convening civil society actors in support of effective policies and programs. One of the things we're working on right now is developing a tool to guide informed decision-making by member states around private sector engagement. We've also supported, we're now on the third phase of the WHO Civil Society Working Group on NCDs and universal health coverage, which has been a really wonderful platform to bring people together. Similarly, kind of looking at capacity strengthening in member states and supporting capacity development for multi-sectoral action. Have a WHO guidance framework on national multi-sectoral and multi-stakeholder coordination mechanisms, and we have also designed and implemented a engagement strategy across the GCM. What I'll really sort of dive in and focus on in this presentation is around our work with meaningful engagement in NCD responses and convening people living with NCDs, mental health conditions, and neurological conditions to really build capacity and have a more inclusive and participatory approach to national health policy and programs. I will be, for the most part, talking about the WHO framework on meaningful engagement of people living with NCDs, mental health and neurological conditions, which has been a multi-year effort that we were really proud to launch in May. I do want to note as well, I won't be talking about this as much, but we also have platforms like the NCD Lab, which has been a really exciting way to bring people together around innovations in NCDs and novel approaches to tackle NCDs. And so I'll be able to show a little bit of that when I get into the Knowledge Action Portal. But in terms of the meaningful engagement work stream, I was actually going to start first by what our definition at WHO is for meaningful engagement, which was a definition that was co-created from the contributions of so many people in the lived experience community. The definition that we landed on is that meaningful engagement is the respectful, dignified, equitable inclusion of individuals with lived experience in a range of processes and activities within an enabling environment where power is transferred to people and valuing lived experience as a form of expertise and applying it to improve health outcomes. I think many of my other panelists this morning have shown really successful examples of community approaches, participatory approaches. WHO certainly didn't invent meaningful engagement or community engagement, but what we've tried to do is bring the community together to really better understand and support member states and WHO to be building meaningful engagement into the way that policy setting moves forward, the design and implementation of programs and services in healthcare. It has been a multi-year effort. The first visual on the screen is the Nothing for Us Without Us, which was a consultation brought together by many people with lived experience at the beginning. And over the last 2 or 3 years, there has been an iterative process to develop the framework and to really build these recommendations out. We've also released a number of reports that People Power shares narratives of individuals with lived experience. Regional reflections is something I would encourage this audience to look at in particular, which breaks down some of the priorities and analysis from a set of regional consultations that happened across WHO geographic regions, including CRO. And the framework itself is much of the beginning of the document really breaks down some of these ideas around power, equity, participatory approaches. And then the second half of the document really gets into recommendations and action for WHO and for governments, for member states. Through this participatory process with so many different experts in the lived experience community, we identified a set of 5 principles that are really underpinning themes that you can't cherry pick 1 or 2. They're foundational and need to, not nice to haves, but needs to have in terms of the dignity and respect of people living with these conditions, power and equity, inclusivity, intersectionality, commitment, transparency, institutionalization, and then really contextualizing meaningful engagement within the sort of specific needs and priorities of each region. In addition to the principles, really broke down some of the enablers that promote successful meaningful engagement. Meaningful engagement needs to be sustainably financed, both in terms of resources going into participatory approaches, but also if people with lived experience are experts, they need to be compensated commensurate to other forms of expertise. Similarly, we break down recommendations for redistributing power, stigma and elimination of stigma, integrating meaningful engagement.
Thank you very much, Maya.
Levels.
This is fantastic and super input to the conference today. Thank you. A round of applause for Maya.
No problem.
I'm so sorry that I've had to cut the speakers off when there's so much more rich input that we could have heard from them all, but I did want to make sure there was time for some comments and questions from our audience. And first of all, I'd like to go to an online participant, to Dr. Penny Vera Sanso. Penny, if you're able to unmute and read the question.
Hello. Yeah, great. So my question, which is in the chat, is basically, and the last speaker addressed some of this actually, began to address it, but you know, everybody's saying wonderful things, but there are underlying tensions that are not being addressed. One is, which is that if systems are based on volunteers, then it's accountability is very difficult to maintain with a system of volunteers, and you have underlying issues, which is the extent of coverage, because you're just based on, you know, relying on volunteers, the continuity of services, that whole, how do you get that shift from, if it's volunteers, how do you get the shift from charity-based to rights-based ethos around provision? And also there's the whole question of local politics, local power relationships, and the fact that some groups may feel excluded, particularly if stuff the volunteers come from particular sectors of the community, and also individuals who may even come from those sectors of the community may feel stigmatized and not willing to come forward. So the question is how are these volunteer-based systems addressing this, or have they yet to get to that point?
Thank you, Dr. Penny. Who would like to have a go at answering that? Maya, do you have a thought on that?
Yeah, I can start. I think it's a really great question, and I know feasibility is a big piece of that. I think one of our recommendations is that we should be shifting away from a volunteer model when it comes particularly to kind of people with lived experience. But that, you know, that there's feasibility there, and it's not always possible. I think when I was talking about sort of sustainable resourcing with meaningful engagement, it is in many ways about sort of compensating people's time and effort, and the respect and recognition of expertise in all its forms, including lived experience. But there's also kind of practicalities and resources around your points in inclusion, thinking about translation or having things in local languages, supporting people's travel time to be part when they have to travel to be part of engagements or be involved. There's all sorts of different ways you can think about that. Outside of the financial components of really the sort of sustainable, equitable way to work with volunteers, I think co-creation and making it a really sort of equitable process is really important. I think particularly with advocates with lived experience, we see so many examples of people are just sort of brought to tell their story, to sit kind of and let all the experts join. And it really needs to be about kind of a really equitable capacity building and building in a reason for people to be there and to really sort of support people in being part of the process, and where there aren't always resources to be able to shift from a volunteer model, still needs to really be a person-oriented approach to bringing people to the table and making it a worthwhile endeavor, both for the organization, but also for the volunteers who are putting their time and effort to this.
If any of the other speakers would like to make a comment on this question, please do come on camera. Otherwise, we may move to a question from the audience in the room, if there is one. And also, I think those online are chatting and commenting on Maya's contribution as well. Okay, we have a question in the room. Please introduce yourself and go ahead.
My name is Robert Gates, Chatham House here in London.
Can we just check that those online are hearing?
Can I add about the gender?
Hello? Yes. I'll sort of shout into it like that.
Maya, now, are you hearing?
Can you hear?
Yes.
Marvelous, great. Thank you very much. It's really a question for all the panelists, and it's around the financing of NCD services and what your thoughts are on the importance of these services, particularly preventive services, being provided totally free of charge and universally available, as opposed to charging user fees. I heard some reference earlier on to sort of resource mobilization from communities, which sort of sets a few alarm bells ringing for me that this might be something around sort of trying to charge people to use these services. Is there a view from Vietnam and Indonesia, in fact, from many of you, as to whether you think these services should be charged for or they should be available totally free of charge? Thank you.
Thank you for the question. Dr. Maria, would you like to come in on this?
Thank you. So for the screening program that we have just put in place, the 14 screening program, those are the ones that is at the moment we allocate funding from the national budget for this. Of course, we are doing it stepwise. We also, some part of it is actually included in our national insurance single payment scheme, but not everything. So we have the national budget, but also the national insurance scheme. So of course, there are more than this screening, but at least there's 14 screening we wanted to start and to make sure that people actually receive this screening. And for this 14, actually the national budget is used for covering this screening. There are also some questions in the chat, if I could respond probably, or maybe later on.
We have to have our comfort break and our coffee break and our tea break, depending on your fancy now. So thank you very much for that answer, and we hope to pick up some more later on. So it's time for a break. If you want to tweet over the break, a reminder that we're at NCDs and at UHC. And I'd like to invite everybody to come back again and rejoin at 10 minutes past the hour. So that will be 10 past 11 UK time. I hope that's clear for everybody and look forward to seeing you back again here at 10 past. Thank you for a great session 1.
Câu lạc bộ là tôi tham gia câu lạc bộ
One thing that I'm not sure is going to be possible, but it's for the music. So I'll see what it looks like. I will see the site. I'm very aware of this is like, but yeah, it was very good. That seems to be working. No, I don't think we want to do that. That is just a classic setting. You can actually see the on your screen share. See the microphone. So that might be it's very honest. We don't how we but so the thing when I can share, which I thought would I don't remember coming up that yeah. But I can't share that one. Okay. I can't do it. Actually, let me see.
Hey. You know the NCD Alliance, come on. Sit. The diverse agrees.
you know, having, I would say that let people know that
Is everything all right? Great. We heard the sound come through, so. All right. There we go. Fair enough. Great. Hey, Dan, so tell me if this is a crazy idea, but so one of the comments, just thinking of how we can allow people here to follow the chat. Could we offer to register people for them to join as kind of on their phones, participants join, get the link? Great. So that's really, really helpful. So how do we share that to, I'm going to go speak to people in coffee and I'll let them know, and yeah, that's great. That's fine. Okay, thanks. Yeah, I'll let them know. Great. So while we're putting together, before we go live again, one of the things that's missing is people having access to the chat online. And so what we can do is we can give everybody a link to join as attendees to the Zoom kind of online thing from your phone devices, so you can actually look at it there. I would have to send that to you. That would be possible. I just have to, I think I got it here. And if you do join, the crucial thing is to make sure that you're muted, because otherwise we're going to have
Welcome back, everybody. I hope you had a good break. Wanted to let you know that we'll be making the presentations and the recording available to you all afterwards. And for you who are online, thank you for all the comments. Please do keep those coming. So, welcome back, and this is now the start of session 2. This is about the power of people, an untapped resource towards inclusive, holistic health. This session is going to focus on what community-based organisations can offer for promoting and supporting healthy ageing as part of NCD prevention and management, and increasing agency and power for individual and collective action. We've got some super speakers lined up. First of all, we're going to go to Dr. Coate, and he's going to talk to us about key lessons and observations from SUNI-SEA research on working with community-based groups in Vietnam, Indonesia, and Myanmar. Dr. Coate was already introduced, so I'm going to invite him up to the podium for his intervention in this session 2. Dr. Coate, you're very welcome.
Thank you. I'm going to give this presentation on behalf of my colleague, Jeanette Lansman, who unfortunately is ill and cannot attend. I want to tell a bit about our experience in working in community groups, and the issues of volunteer come back in this discussion as well. I will not quote these interviews, but there's a clear difference between younger people and older people with regard to their interest in NCDs and health. So if we talk about community approaches, we cannot have one size fits all approach. We must pay attention to the different interests and needs. And of course, you all know this model that WHO applies of the life course approach, where you see that there's a gradual reduce in health status with reduced vitality, and then chronic diseases, multimorbidity, and then finally complications where people die of. So in different life course stadia, people have different interests and different problems with their health, and therefore we need to approach them in a different way if we want to have community engagement in health. So for NCDs, what we found in our project is, first of all, knowledge is very important. And then we say, okay, knowledge. But we did these surveys in Vietnam and Myanmar and Indonesia, and people confuse diabetes with an infectious disease, or they think if you get one course of antihypertensive medicines that then you cure hypertension. So that is very important that we first increase knowledge. Then, as was mentioned already by Maya, experience with chronic diseases makes a lot of difference. Patient organizations and peer support is a very particular approach that helps in getting interest for NCDs. Health literacy is very important. Education level plays a big role in getting people interested. So we need to take all those circumstances into account where we see what can facilitate. On the other hand, poverty. People have other problems to survive rather than thinking about their future health later on. Access to services is very important, which was already mentioned by Dr. Maria on access to services in all communities. Then there's a huge misinformation. There's still a lot of advertisement for tobacco, for alcohol, for other fast food that informs people in a wrong way, and we really need to fight against that as well. And then we need to find this right strategies to engage with people. And so we already had these examples of the intergenerational self-help groups and post-Bindu. What makes the difference, we just talked about it during the break as well, that in the self-help groups you have people, one does a bit on health, the other does on economic development, the other does more on the social engagement. So the volunteers help each other, and there's not so much that one volunteer has to do all the work for all the others. It's mutual support. Well, in post-Bindu, it's much more an extension work, and the volunteers are more working as extension work, and therefore what they get back from their work is different than in a solidarity group. What helped us to work with the groups is co-creation. People must feel ownership. They have done a lot of the ideas and how it should be implemented come from them, and we try to work in a culturally sensitive way to get the best out of the groups. The second important part is easy access, reduce the barriers, and free access to health education, to health promotion, to screening, and much easier access to information, and use social media as well, and make sure that people bring their friends and families to come and join. The peer support was already mentioned, and that's very important, where people help each other. If I tell something to a patient as a doctor, it is a really different situation than when somebody who has a living experience tells a person how to change health behavior. And of course, what was mentioned also before is the community leaders. We should engage with them. And so all these different strategies are very important to really get communities on board in health activities. For volunteers and cadres, the question was already mentioned. Intrinsic motivation in our interviews with volunteers is very important. People like to help others, but there's a limit. They should not become unpaid employees. And the question was already raised by Maya, and it is mentioned as well by others that we should make very clear what we expect from volunteers and don't over ask them. What we found is that often we are over asking volunteers, and they have problems with IT, they have problems with medical technical things. So therefore we need very good support to volunteers to maintain the quality. We cannot just give them one instruction on how to use electronic medical record and expect that they understand everything. You need to go through all the steps and help them throughout a longer period of time. So what we need is continuing support from local authorities, financial resources, but also giving them respect, giving status, giving the necessary support to continue voluntarism. Policies are important. Health workers should continue to work together with volunteers and communities to continue engaging them and working with them. Digitalization has a future. It's very challenging, what we found in our project, because all the people have limited digital literacy, but in the end it will help. And in Myanmar, we were able to show that people are able with support to use many of the electronic systems that we introduced. So in the end, where it's all about is pushing up the curve that we, together with the people with whom we work, will have a longer, healthier life than now. and that motivation is very important in community work, that it's not about health. Health is just a means for a goal, and that is better life, better quality of life. And if we can motivate people along those ways, the community engagement works very well. Thank you very much.
Thank you so much, Dr. Coate. Thank you. So next we're going to hear about the role of Myanmar's inclusive self-help groups and other community organizations in health and well-being amid crisis. And we're going to invite Dr. Anil Krishna, Director of the Center for Leadership in Global Health Equity at the University of Global Health Equity, Kigali, Rwanda, to speak to us. Anil is a Professor of Global Health and has served as Professor and Dean of the School of Public Health, SRM University in India. Before joining the University of Global Health Equity, he worked with HelpAge International, leading the public health research and interventions on NCDs in Southeast Asia. So, Professor, over to you. Dr. Anil is not available. We can move to the next speaker and come back to Dr. Anil. Dr. Anil, are you there? Okay, we'll come back to you, Dr. Anil, and we'll move on to hear about the experience of older people's associations in the Philippines in advocating for better healthcare in the community. So I'd like to invite Bonifacia Vasconcelio, Advocacy Chairwoman of the Confederation of Older People's Associations of the Philippines, to speak with us. So Nani Paz is a passionate champion dedicated to enhancing the well-being of older people. She actively advocates for the promotion of older people's well-being and collaborates closely with the Coalition of Services of the Elderly to spearhead campaigns focused on universal health coverage and other health-related concerns. She's been instrumental in advocating for the Philippines' universal social pension, as well as other bills aimed at addressing the needs of older people. Nani Paz, are you there?
Yes. Good day, everyone. I'm Bonifacia Vasconcelio, a 74-year-old senior citizen of the Philippines. I'm at present the chairperson of the Confederation of Older Persons Association of the Philippines. COPAP is an organization established in 2006 with 14 federations, 130 OPOs, and 4,500 members. Being a community-based program organization of the elderly, we have established different programs to address the different needs of our members, such as livelihood, health, disaster risk reduction management, burial fund assistance, and advocacy. We want a better healthcare program to address the health needs of older persons. So COPAP, together with COSE, or the Coalition of Services of the Elderly, advocated for the establishment of community-based care healthcare programs called Home Care Assistance Program since 2003. Then it was adopted by the Department of Social Work in the Philippines in 2010. Home care program established in the communities where COPAP members are present. Trained home care volunteers do visit sickly and bedridden older persons, taking vital signs, determining whether client has to be brought to a healthcare facility for more specialized care. Volunteers do help members of the family of the clients in taking care of those bedridden members. From time to time, medical students from different universities do internship in our communities. The students help us improve our program, and they also learn from our experiences. In terms of advocacy, we want the government to listen to our needs. I myself represent COPAC in a network of civil society organizations called ABI Health, or Alternative Budget Initiative for Health Sector and Social Watch Philippines. COPAC, together with its network, lobbied for the passing of cheaper medicine bill, which was enacted in 2008. This bill, this law provided for the affordable quality medicines for all Filipinos. COPAP also with COSE also advocated for the passage of mandatory PhilHealth coverage for all senior citizens. The law was enacted into law in 2014. The law mandated no balance bidding for senior citizens when they are confined in government health facilities. PhilHealth, or the National Health provides the and pays the bills. Our advocacy continues, and this time related to the universal health care. Together with the networks of Social Watch and ABI Health, COSE and COPAP joined the call for the passage of universal health care law. The law was enacted in February 2019. The law covers health care by putting care facilities at the community level and providing healthcare workers in all these facilities. As we all know, there is a shortage in the healthcare workers in the Philippines because most of them migrated to different countries for a higher salary and income. In order to augment the shortage, its local government trained healthcare volunteers called the barangay health workers. And the government, or the DOH, the Department of Health, formed a program called Scholarship for all students who want to take up medical courses. In this situation, the scholars are required to render community service for 3 years after finishing their courses, and they are called doctors to the barrio. LGUs also train barangay health workers. the LGUs and DOHs also provide maintenance medicines for all those who have NCDs. The implementation of USC is not fully implemented because of lack of funding. Much of the funds of the government were used for COVID-19 response. Actually, COMPACT and COSE joined other civil society organizations in calling for increase in syntax for added funding of the universal health care. Through this increase, the syntax, the government said they still lack funding. The benefits derived from the syntax also reduce in the consumption of cigarettes and alcohol, which resulted in the reduction of diseases caused by these products. Last February, the DOH conducted consultation with different civil society organizations for their budget preparation for 2024. And for the seniors, I suggested the establishment of geriatric centers and geriatric wards to cater to the needs of senior citizens. And also, I suggested for the increase in the funding of scholars to train as geriatric care, to train on geriatric care. So,
Nanny Paz, thank you. If you could just wrap up now, that would be super. Thank you.
Thank you.
Great to hear from Nanny Paz. Do we have Dr. Anil with us? Otherwise, we'll move to Kira Koch. Do we have Dr. Anil? No. In which case, I'd like to move to Kira Koch, Technical Officer, Special Programme on Primary Healthcare at the WHO, for some reflections on examples of social participation in universal health coverage. So Kira currently works in the Special Programme on Primary Healthcare. As part of the governance team, she focuses on health system strengthening, performance assessments, and participatory governance to support countries on their path to HC. He's a co-editor of the WHO Handbook on Social Participation for UHC as well. Kira, thank you for being with us. Over to you.
Thank you very much, and I hope you can hear me. It's a real pleasure to be here with you today, and it's very interesting to hear the insights and learnings from the SUNI-SEA project, and our speaker just now talking about the experience from Philippines. And I think it's very apparent that the engagement of communities are necessary in how we are delivering the services. But I also think it's very important that people, vulnerable communities, patient groups, civil society organization are also brought more into decision-making processes at the national level, so that the strategies and policies and plans are more responsive to the needs of the population. And this is what I'd like to speak to you a little bit more about by providing you with some of the examples of social participation in universal health coverage. And what I mean by that is that systematic government engagement with the population, with communities, and with civil society for national health decision-making processes, such as, for example, with the remit of a new national health plan, a PHC strategies, where certainly issues around NCDs play an important role. Now, we've heard already a lot about the importance of primary healthcare. So I just like to remind ourselves that primary healthcare is really that whole of society approach to health that aims equitably to maximize the level of distribution of health and well-being by focusing on people's needs and preferences as early as possible and as close as feasible to people's everyday environment. And we have that comprehensive definition of PHC, and you can see here on your screen the three interconnected components: the primary care and essential public health functions as the core of integrated services, the multi-sectoral policy and action, and also that very important component of empowering people and communities. Now, what have we done? In 2021, actually, the World Health Organization published a handbook on social participation. You can see it here on your screen and the link below for those who are interested to peruse through it. And this was really a collaborative effort over the last 2-3 years with an internal group. We had an external advisory board with government representatives, academia and civil society, including, for example, the NCD Alliance. We did many literature reviews and also 9 country case studies across the region on the basis of which we have put forward our recommendation. And I've just put a couple of ones here, for example, the National Health Assembly from Thailand, the National Health Council from Portugal, the experiences from Tunisia in terms of their experiences with the Dialogue Sociétal, the India's National Rural Health Mission, but also, for example, a civil society-led community health system strengthening approach from Madagascar. My point here is really that this book aims to provide practical recommendation on the how of social participation, and it particularly aimed, as you can see here, towards government and policymakers on how to more meaningfully engage with the population through communities or via civil society for those national health decision-making processes for UHC by leaving no one behind. Now, here you can see actually the overview of the handbook chapters, and these are the key issues for policymakers to reflect on when setting up, when strengthening, and when institutionalizing those participatory mechanisms, such as, for example, creating an enabling environment, thinking through issues of representation, also about capacities on both sides, government and civil society and population groups, as well as the important link to facilitate policy uptake, legal frameworks, and also sustaining participatory engagement over time. Now, in the interest of time, I won't go into all of the details, but just pick a few chapters to come across some of those key messages. And I'd like to start actually with chapter 2, where we lay down the fundamental premise of this handbook, and that's about power dynamics. Because power dynamics are ingrained in a country's political, social, and economic landscapes, and they create unequal conditions for participation because they pose those structural barriers to participation for some parts of the population, usually those who have less of a voice, and inadvertently increase access to decision-making structures for others who already use to have and hold power and influence. So meaningful participation is really about evening out that playing level field within the participatory space as far as possible. And what we mean by that is to counterbalance those inherent and ingrained power imbalances that exist in every society for purposes of that participatory space. So the point here really is that participants who are generally weaker and less powerful are empowered to the maximum extent possible to express their views and experiences without fear of reprisal or undue consequences. And that actually signifies, and that's a difficult part, a humbling of voices of those who usually hold powers, such as policymakers and governments. But ultimately, and this is really what we would like to come across with this handbook, it is beneficial to everyone, especially to those with power and influence, as it has an enabling environment that can act as a great catalyzer for the participatory process. And then it can be that very potent tool to minimize power asymmetries if, and that's certainly a big if, designed in a way that counters those barriers. And there are different ways to lend those with less voice and agency countervailing powers through format and design of participatory spaces. And starting, for example, with the very complex issue of representation, because the issue of representation is so closely linked to the issue of legitimacy and credibility, the widely held notion that if those who are part of the participatory process are representative of whom they are supposed to represent, then they are also considered legitimate. And more importantly, the results of those participatory processes are then also seen as legitimate and facilitate the policy uptake. But again, legitimacy and representative is not something that is very inherent or the inherent quality of a person per se. It's also something that needs to come across through a well thought through participatory process. And here it's really about being transparent and explicit about the selection criteria, how to select participants and the roles of the participants. For example, why it is important for the policy questions, let's say an NCD strategy, that we need to listen to the experience of a community representative living with diabetes. And this needs to be clear for everybody across the table in order to make sure that we want to know from that person to ensure that the lived experiences is also being taken into account. Now, there are a couple of format and design elements of participatory processes that can largely influence the ability to effectively take on those representational roles. And I've just put a couple of ones on the screen, such as neutral facilitators, homogeneous focus groups, but also, for example, in the case study of Madagascar, it was very important that people went into the rural communities and not expecting them to come to the bigger cities. Also considerations about the language, to do those consultation in French or in Malagasy was very important. Usually across, we see that a mix of various participatory processes and mechanisms from open to mic and all events, focus groups, citizen juries allow for a broad range of people to interact. And this was actually quite important for the experience of Tunisia societal dialogue, where especially at the beginning, there was a lot of mistrust between different actors, between government, healthcare professional, and citizens. So it was very important in the first place to listen and reach out to many Tunisians across the different regions to understand better their challenges in accessing healthcare. Or maybe my last example from Portugal, the National Health Council, you have 6 out of 30 seats which are reserved for civil society, but also there were feeling limited sometimes in their ability to represent the vast interest of the Portuguese population, but also for them to have this adequate time to study those preparatory materials to take up their representational roles. And my last point here is also on the capacities, because it's again about recalibrating the balance of power, which is rooted not only but largely in expertise, knowledge, and speaking skills. And we know that the quality of exchanges is largely determined by the competency of the participation, but it's also that capacities of government actors to enable that level playing field for those really good and frank and fruitful discussion to happen. And we've put forward 3 main capacities for social participation. The first one on recognition, really understanding the added value that it brings to policymaking, communication skills, not only to listen, but also to provide feedback, for example, after a participatory process, and those technical skills in order to understand power imbalance, and then also through the format and design, mitigate those in order to allow for a meaningful participatory process. Now, maybe a last example from Thailand.
We have to
okay, we have to keep up. All right.
Kira. Thank you very much indeed.
You're most welcome.
I'm delighted that Dr. Anil has managed to connect with us. So we would love to hear from you, Dr. Anil Krishna, about the role of Myanmar's inclusive self-help groups and other community organizations. Dr. Krishna is director of the Center for Leadership in Global Health Equity at the University of Global Health Equity, Kigali, Rwanda. Over to you, Dr. Anil. Thank you.
Thank you very much, and apologies for joining late because of the connection issues. Can you just start with the slides? Hi, good morning and good afternoon, wherever you are. So to begin with, this on behalf of HelpAge Myanmar, I welcome all of you to this presentation, the power of people and untapped resources towards the inclusive and holistic health. So, I'm sorry. Okay, let me begin with what is exactly worked in Myanmar, the ISG model, which is, basically when we talk about the, improving the social capital. The intergenerational self-help group, which is led by older people and representing the cross-section of the community. They provide the services at the doorstep to the people who are in need of services, especially through this project, the NCD services. The unique model, which is maximizing the opportunity for the intergenerational collaboration in delivering the health services. The uniqueness of this model is identifying the high-risk group through a house-to-house and screening, and linking them, essentially to the nearest primary healthcare facilities or the, public healthcare facilities where the NCD services are currently available. In addition to the NCD services, the ISGs also address a range of community needs like livelihood and other social initiatives. As I move to the next slide, which essentially talking about the self-care of the community and the family, where the ISGs are providing services. The SUNI-SEA project introduced a self-care application with the aim to build the capacities of the individuals in the community to stay healthy, especially when the healthcare services are not available. Say, for instance, during the COVID, there was a big issue of that. In addition to the ISG, which build the capacities of the home care volunteers to provide health services in their respective villages. Then, based on the experiences of the, self-care and other related activities, the self-care app, which is currently showing in the screen, is an innovative idea of the project team, which was developed and tested and implemented about 6-7 months ago. The app is a bilingual in both English and the Myanmarese and user-friendly. I'm proudly saying that this is a model, is a brainchild of HelpAge Myanmar team under the SUNI-SEA project. See, when you look at the data, and we did an analysis of the data in which we found that over 2,000 individuals have been downloaded the application in a short period of time, and over 1,800 individuals have been screened for NCD and mental health conditions, which is the outcome of this one. When you look at the data, which is around 12% of the screened individuals have been referred to the nearest health facilities. Out of the referral patients, if you look at around 50% of them were diagnosed with one or more NCDs. We believe that in the absence of the self-care screening app, some of the people might have been not receiving the treatment. And with the help of this app, people started analyzing their health condition. As I move to the next slide, which is okay, sorry. When we talk about the specific achievements of the ISG as part of the SUNI-SEA, the major achievement of the ISG model is to improve the access to the basic NCD services in the place where the project is being implemented. As a result of the early risk assessment of NCDs and the mental health, the communities have been practicing the healthy living. increased awareness, essentially on the risk factors of NCDs and the prevention modalities. More people are coming forward to accept this model. This model has a very high potential to scale up, as it is a low cost, high impact intervention. See how the ISGs played a role in achieving the universal health coverage. When you look at the whole entire model of this ISG, which is a community-driven model, where the group of people, which is from the older person to the youth, they were all connected with the community and providing the services. This project is further widens the scope to connect with different institutions to expand services and the resources provided to the communities. The resources in terms of, the information, the knowledge, the awareness on the various activities which is led by the group. And the important factor when we talk about this group is it's a door-to-door services where they reach out to the people, those who are not able to reach out to the nearest health facilities for various reasons. One more important factor when you look at the coverage of universal health coverage is ISGs, which build the base in the community and increases the availability of health services. When you talk about the availability of health services in terms of the screening, the screening part, which using different models. One is using the self-care app, and in the beginning of the ISG as a model, they provided services to the people on screening of diabetes, hypertension, using different models. This model also
2 minutes, Dr. Anil.
Yeah, this model brings financial sustainability to the families of the ISGs, and also by providing the financial support to access the healthcare for the poorest of the poor, the patients help them to seek healthcare without any further delay. When I talk about the one of the major role of this ISG model is which is not only providing the support to NCD initiative, rather it is providing a support to the overall well-being of the population by saying that they're also providing the livelihood support and in addition to the health. That is the major component in providing support to the entire community, and we hope that this is going to be one of the cost-effective model in a fragile states and conflict-affected areas, which could be a sustainable model, which could be replicable across the country and across the region. Thank you very much.
Thank you so much, Dr. Anil. Fascinating. And now I'd like to invite Charlotte Aberdeen to come and give us some global examples of empowered, engaged communities making progress on NCDs. Charlotte is with the NCD Alliance. She joined in February this year and is responsible for the Our Views, Our Voices initiative, which seeks to put people first in the NCD response and to ensure no one is left behind. So prior to this work, Charlotte was in Cambodia with GIZ, where she provided technical and capacity development support to the Cambodian Ministry of Health. And she was also instrumental in co-founding in 2018 the Cambodian NCD Alliance, which has been calling for accelerated action on NCDs. Charlotte, you're very welcome.
Thank you. Yeah, it's my pleasure to be here today and to hear all of these rich presentations and about all of the community engagement activities that are happening, particularly in the 3 countries that we're focused on today. I'll be speaking about the importance of engaged communities or community engagement in the NCD response. I'll start by giving a brief background of the Alliance, highlighting the political momentum we've seen in community engagement. Then I'll share a bit about the Our Views, Our Voices initiative, which is the area that I work on at the NCD Alliance in the capacity development team. And then I'll finish by sharing some examples of activities by alliances in a few different countries. And I will whiz through this because I know that there's not that much time. So for those that don't know the NCD Alliance, we were founded in 2009, and there are 4 founding federations: the Union for International Cancer Control, the International Diabetes Federation, the World Heart Federation, and the Union Against Tuberculosis and Lung Disease. And the picture at the bottom here is actually back from kind of pre-COVID times in Sharjah, bringing together all of kind of civil society network, alliances, various partners, just to kind of discuss lessons learned. And yeah, this was one of the last times everyone was together, but we're hoping to bring everyone together for a forum in Rwanda next year. So without going into the detail of our strategy, I've put this slide on here because you can see in the orange, these are our impact goals, and one of the impact goals on the right is community engagement. This is a standalone area for us, a really important area of our work and what I'm speaking to today, but it's also an enabler for our work on financing, care, and prevention. And so this is all about strengthening the capacity, sustainability, and involvement of civil society and people living with NCDs in the response, which is obviously what we're here today to talk about. So in the last few years, particularly since 2017, 2018, we've seen some major political momentum on community engagement. Back in 2018, the Director General of the WHO convened a civil society working group on NCDs to promote the meaningful engagement of people living with and civil society in the lead up to the high-level meeting. And then following the high-level meeting itself, we had the political declaration, which included a significant commitment by governments to the meaningful engagement of civil society in supporting the development of national NCD plans and also amplifying the voice of people living with in the response. I've included other examples here of the high-level commission and also the Global NCD Compact, as both of these included recommendations and commitments to meaningful engagement. And then the World Health Assembly back in 2021 extended the mandate of the Global Coordination Mechanism, which Maya Olsen was referring to earlier in her presentation. And this is really significant because it's the only instrument which facilitates multi-stakeholder engagement on NCDs. So it's critical for convening civil society within the WHO framework. The GCM, and Maya touched on this, they have labs, and there are 3 labs, and one of the labs is specifically on the meaningful engagement of people living with NCDs. So this is a unique opportunity to showcase innovative tools in this area. I'm not going to say much on social participation, as Kira had that covered in her really comprehensive presentation, but just to say we see this as a key enabler for achieving UHC, and we're expecting to see a lot of momentum in the next year, with Slovenia and Thailand championing a resolution ahead of the next World Health Assembly, and also the WHO framework on meaningful engagement, which Maya obviously touched on quite comprehensively as well. This is really, really significant for our work, and it's all about providing technical guidance and support to governments and to WHO country offices. And we're hoping that we will see more institutionalization of meaningful engagement at different levels of the response. So we can just play the video. Thank you.
Hey. You know the NCD Alliance, come on. Sit to the NCD, 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 NCD.
Thank you. So this is the Our Views, Our Voices initiative. We've just celebrated the 5-year anniversary of this important initiative, and this is all about putting people first in the response. So not speaking for, but letting people speak for themselves. And I think, you know, we're learning all the time about how we do this effectively and inclusively, and it's really a fundamental part of an inclusive NCD response. Oh, okay, great. So yeah, a kind of touchstone of the Our Views, Our Voices initiative is the advocacy agendas of people living with NCDs. And back in 2017, we had the first global advocacy agenda, which consulted 2,000 people were living with NCDs around the world. And since then, we've seen the development of 9 national advocacy agendas. There's one currently being developed in the Philippines, and there is a regional advocacy agenda in East Africa. So we really see the role of civil society under kind of 4 important areas. These are advocacy, accountability, access to services, and also awareness creation. So just to very, very quickly highlight 3 different initiatives or activities conducted by alliances around the world. The first is specifically focused on access in Malawi, and this was all about leveraging member capacity to improve access to NCD services in rural areas. They followed a 2-pronged approach, which combined both awareness raising and also providing access to screening. So they were really leveraging their members. Often alliances are comprised of many different members, bringing different expertise on different diseases and risk factors, and they were leveraging this expertise for different screening initiatives in areas with low awareness. For example, people providing hypertension camps were assessed using a broader NCD checklist and received advice about all NCDs and their risk factors. Members involved in this initiative learned the importance of integrating NCDs beyond those of their immediate focus, and we've really seen this lay the foundations for integration work in Malawi. Sorry, I think I'd skipped a slide there. Accountability work in Ghana, which is really innovative, is on community-led monitoring. This has seen the Ghana NCD Alliance actually utilize a community scorecard system that was developed by the Ghana Health Service and the Ministry of Health, and they have incorporated NCDs within this. And then just quickly on advocacy in Kenya, we've seen huge strides in the advocacy work there, with the Kenya NCD Alliance actually being centrally involved in the development of the National Strategic Plan on NCDs, and we've got people with lived experience sitting on task force on mental health, and we're actually seeing really important work at the county level with technical working groups that include people with lived experience. So just to quickly summarize, and I won't go through all these points, a strong NCD response means strengthening capacity, sustainability, and the involvement of civil society and people living with NCDs. Something that is absolutely critical is a conducive enabling environment. And you know, in many countries, and we haven't really acknowledged this today yet, but where we're seeing shrinking civic space, advocacy work, work on prevention, commercial determinants is increasingly challenging. So that is something that is really, really critical. Yeah, civil society plays a key role in many, many different areas, and it's essential to put people living with NCDs at the heart of the response. Thank you.
Super. Charlotte, thank you very, very much indeed, and a great video to wake us all up as well. So now we can move to some questions and answers, and really looking forward to hearing your comments, your questions. Just to start us off, we've noticed a theme coming through the chat, which is the burden of responsibility that is being given to volunteers and to family members, and there are gender equity issues arising from that. So I'd like to ask the question, What is necessary for ensuring that community-based approaches do not reinforce inequalities in a community? Perhaps Dr. Coate, perhaps Kira, perhaps Charlotte, you would like to respond.
There's a technical problem.
We are not streaming at the moment. Could we just hold for a second while we try to get back online?
Yeah.
We just lost our connection.
Yeah. Well, I get messages from people who are online that the meeting has been terminated.
Maybe we had a time limit. Looking positive. Hello, welcome back. Welcome back. That was a technological glitch. I'm very sorry. I think we're back online now. So, thank you again to all of our presenters from that session. Now it's time for some questions and answers. And what we've noticed coming through the chat is a theme around the burden that is being put and the responsibility that is being given to volunteers and to family members, and that includes gender equity issues. So, synthesizing some of those comments, I wanted to ask the question, what is necessary to ensure that community-based approaches do not reinforce inequalities in a community? And I'd love to hear from some of the panelists their thoughts on that. So maybe Dr. Coate, maybe Kira, maybe Charlotte, maybe Nanny Paz, if any of you would like to make a response. Dr. Coate.
Yes, it is very important to try to get all different parts of communities engaged. I know, for example, that in the ISHCs, they have a kind of goal to have at least 70% of the members being women, and also having older people engaged. So they use a kind of quota trying to get the disadvantaged people really participating. So that is one way. In Indonesia, they have an active approach of getting men involved as volunteers because the majority are women. So indeed, if you want to have all different stakeholders involved, you need to actively target those populations in the community that are disadvantaged or less willing to participate. So active approach is necessary, but on the other hand, you don't want to really impose too much on a community, because you want spontaneous actions as well, and you want the people who are really willing to engage to be possible to engage. So it is a balance that you have to look for, trying to make sure that all voices are being heard.
Dr. Coate. Thank you so much, Dr. Coate. Kira or Nanny Paz, would you like to come in on this question?
Yeah, thanks very much. And apologies, apparently we had a technical glitch, but so I have just understood the last second part of the questions. But I think in relation to what my previous speaker has just mentioned on how we can actually meaningfully reach a lot of parts, I think it's very important that different mechanisms are actually used in order to reach different people. And I think that's what I've mentioned also in the chat box. It's very important that we ask ourselves who is participating and who is not participating. And then doing this extra effort that is always needed in order to reach those who are usually left behind, in order to go into the different communities, in order to use different participatory options, like those open to all forums, but also those specific focus groups, because it's ultimately also that safe space that we would like to create for everybody to express their viewpoints without fear of reprisal or undue consequences, because power imbalances will be there among different actors. Maybe I stop here, and I hope I was answering to some of parts of the question, and apology for the technical inch again. Thank you. Over to you.
Yes, a very interesting response and very helpful. Nani Paz, would you like to give us your thoughts?
Actually, we should consider intergenerational participation so that everybody will be included within the for this so that everybody is tapped for this kind of services. Intergenerational.
Yes, intergenerational, very important. And right there in the name of those self-help clubs to make that clear to everybody. Good. Do we have a question from the room? Otherwise, I'm happy to take another question from online. Yes, please. The mic's on its way to you. Please do introduce yourself.
Hi, thanks so much. I'm Rachel Allbone. I work in the Ageing and Health Unit in WHO based in Geneva. It's not a question, actually, it's a reflection on the point that it's just been being discussed. I think for me, there's a difference between where we're talking about participation and meaningful engagement, and when we're talking about being reliant on community members to deliver services. I think the social participation point is absolutely key and has been discussed at great length today. I imagine the questions and reflections coming through on the chat around the concerns about reliance on community, I imagine are more linked to where we expect or rely on community members to be the people delivering services and doing the job that the health or care system should be doing. So I just wanted to kind of make that distinction. Thanks.
Thank you, really helpful distinction. Okay, last couple of minutes of the Q&A, and then we're going to move on to session 3. So a last thought, comment or reflection? Anybody in the room? Anybody want, is there anything key to pick up online? Okay, well, thank you again to our excellent speakers from session 2. Thank you all. And I'm delighted to move us on to session 3. So this is a conversation with policymakers, and we're going to focus on opportunity to action in shifting power to people and investing in effective integration of NCDs into UHC primary healthcare services, considering genuine participation and partnership with communities and health interventions at global, regional, national, and local levels. So we have a great panel. In addition to Dr. Wang and Nani Paz, who we've heard from already, we have Gujjagar Ghosh Oceanic, we have Rob Yates, and we have Srinivas Tata. So let me just introduce them. And Rob, perhaps you'd like to come up since we have you here in person. So Greg is team leader for non-communicable and infectious diseases policy program, oversight and planning in the Directorate General of Research and Innovation at the European Commission. He's responsible for non-communicable and infectious disease policy program oversight and planning in the unit Combating Diseases in the Directorate of People. And he has a wide range of experience in program and policy development, research funding, and project management. So Greg, great to have you with us. Rob, who we have here on the stage, is Executive Director for the Centre for Universal Health at Chatham House. He's a political health economist specialising in universal health coverage and progressive health financing, with principal areas of expertise in the political economy of UHC, with a focus on advising political leaders and governments on how to plan, finance, and implement national UHC reforms. And we have Srinivas Tata, Director of Social Development Division at UNESCAP, so that's the United Nations Economic and Social Commission for Asia and the Pacific, where he's been serving as a Director of the Social Development Division since June 2019. He has 16 years of experience working with the United Nations and is a physician by qualification, with experience in finance, taxation, social policy, public health, and program management. So all sorts of really interesting perspectives. And the way that this is going to work is that each of the panelists has a specific question to answer briefly, and then we're going to invite the panelists to comment and reflect on each other's answers before we move into a more general conversation. So Greg, we're going to start with you. The European Commission has considerable experience investing in research to better understand how to tackle NCDs. What suggestions do you have for fellow policymakers and researchers on how to channel greater investment into research on community-based and primary healthcare NCD interventions? Over to you.
Thank you. So good afternoon or good morning, everyone. Thank you very much for inviting me to this very interesting conference. I would like to also congratulate all partners of the SUNI-SEA Consortium for the excellent job they presented here today and they did in the past years. So concerning the question, I think somehow they were already answers to these questions. So what I can add is that what we need the very early engagement, but not only researchers and policymakers, but all stakeholders, including communities, patient organizations, funders, healthcare providers, to understand, also identify demands, needs, what are the priorities, and also what is feasible. And with such a strategic thinking, we might have a very well-informed investment in the areas of community-based or primary healthcare NCD interventions. So this is what I think is also the way to be successful in providing the evidence for the policy making, which is in fact the main reason of doing certain research and putting the things forward in the area of health research. Thank you.
Yes. Thank you so much. So Rob, we're going to move to you. Given your work promoting greater involvement in universal health coverage globally and your work with national governments, how much do you think the international community is taking into account the need to invest in NCD prevention and management, especially at the primary healthcare level?
Well, I'd have to say really that if you were to look at the evidence, that the international community is doing very little, and it's getting worse, unfortunately. And I think as well, what one recognizes that, this isn't just the international efforts, it's within their own countries. That I think if you look objectively at health spending here in the UK, you see a sort of disproportionate amount of funding being allocated to curative services and a neglect to preventive services. And also we've been discussing issues around the social determinants of health. And unfortunately, on numerous issues, be that around sort of access to food, advertising to children, air quality. I mean, this week here in London, in fact, we had a pollution alert, I think on Tuesday, basically encouraging people not to go out that much because the air quality is so bad. So we're not doing these things in our own countries, and then internationally, I think we're seeing it even worse. And we're seeing health aid in free fall at the moment. The UK has got rid of the Department for International Development, has really slashed health aid financing across the board, but we're seeing other governments doing the same thing as well. So this looks a pretty bleak picture, and I think it is, and I think unfortunately you're seeing a number of donors sort of retreating actually away from the NCD agenda and concentrating more and more on infectious diseases and maternal child health services. Now, obviously they need support too, but the overall picture is bleak internationally. But in many respects, I think we can use this as an opportunity to recognize that at the end of the day, what you really need is much more country-led leadership on this, and domestic public financing is the answer to this. So many of the things we've been discussing this morning, at the end of the day, cry out for domestic tax financing to deal with these problems. And I think the real politique of the situation at the moment is that international aid financing isn't going to solve these problems. And, it's beholden on countries, particularly, the low middle income countries, the likes of Vietnam and Indonesia. At the end of the day, they're going to have to domestically finance these things. And I think, it's just vitally important to put this right at the center of development policy in these countries and take it to the ministries of finance and the presidents to do something about it.
Absolutely. Yep. Thank you so much. So, Dr. Wang, if you're with us, we have a question for you.
Yeah, so please.
Come on.
Yes. Can you hear me now? Hello? Can you hear me?
We can hear you, but probably
okay.
In London, they don't hear you.
Yes. Oh, I'm sorry.
I think we can wait just for a minute.
Yeah, we can wait. Okay.
Yeah. Can you hear me asking your question?
I can hear you, but not yet the question. So can you repeat the question, please?
You are a policymaker in national government with a broad area of responsibility. How best can international stakeholders support the work that you are doing to engage local communities and strengthen NCD interventions at primary healthcare level?
Yeah, okay. So thank you very much for the questions. Firstly, I would like to say that actually I'm not policymakers, but as being the researcher who we work very closely with the policymakers and sitting in the policy development committees. So I think for this question, I can respond for that. So from my point of view, and including from Vietnam, from our experience, we see that the international stakeholders plays very important role in the promoting intersectoral actions and helping the engagement of community in strengthening the NCD, prevention and control at primary healthcare levels. So what the international stakeholder can support, like in Vietnam, I see several activities that the international can support. Firstly, international organizations can support the country to organize or even participating in the stakeholder consultation meetings with the policymakers, relevant health managers and healthcare providers, or social with social organization in the communities. So for this stakeholder consultation meeting, the international experience can share the experience for the countries, know how to implement the policy effectively, or can give the advice for the countries on what should be the best, what are the best intervention for the countries. The second, the international organizations can support the country, and together with the country, not can support, together with the countries, can work closely with the police, with the Ministry of Health and other related ministries, minister of other sectors, to promote the intersectorial actions and intersectorial policies. The third, the international organizations can provide technical support and sharing international experience, as well as support in strengthening capacity of related stakeholders. And another thing is very important is that international organizations can facilitate networking for sharing for shared learning and support. The country can share the experience between different countries, and also in terms of the policy development and policy implementation regarding for the NCD prevention and controls. So I see that like in Vietnam, international organizations is very important, play very important role in the NCD prevention and controls. So thank you.
Oh, thank you. Thank you very much. And so Srinivas, turning to UNESCAP, your organization is not really focused on health, but your work in the region recognizes the importance of health and community engagement. So given your experience working with partner governments across the region, what advice can you offer policy stakeholders seeking to achieve better investment in NCD prevention and management at community level?
Thank you very much, Madam Moderator. I really thank Age International for inviting ESCAP, though we are not a pure health agency, but I do have a response on that, the importance of that. Firstly, just a little bit on ESCAP. We work on aging. Though we don't work purely focused on health, we are the regional organization that works extensively on older persons. And as you know, health is a very important part of the Madrid International Plan of Action, and a lot of our energies have been in working together with other members in the ecosystem, including UNFP and others at regional level, especially on strengthening the delivery of healthcare to older persons, because that is one of the needs that's most lacking in our region. We've been working on the UN Decade for Healthy Aging. That again acknowledges the need for organizations outside the health sector to be involved. So I'd like to make one point here. I think it's so important for agencies which are not within the health sector also to be engaged in this. UNC cannot be achieved by only advocating within the health sector. We need to get more organizations outside the health sector. We need champions across the spectrum. I believe health is everybody's business. And I can say that I'm a doctor, I'm a public health person who's worked in the Ministry of Health in a previous avatar, and I believe it's becoming more and more. Now, as to the relevance of this, a lot of the discussions that have taken place, when I intervene now, I find coming after so many rich presentations, and when you're coming in the last panel, I will find myself repeating some of the wonderful and very wise words that have been spoken before me. For my region, the Asian Pacific region, it is the fastest aging region in the world. By 2050, 1 in 4 will be 60 years or older. So especially tackling NCDs is very critical. I mean, we know younger people also having increasing NCDs, but for older persons, it's even more important. And since this is something that contributes to both aging and NCDs, I'd like to focus on issues that affect both and increase them, address them together. My first message to policymakers, and I'd like to reiterate what Rob Yates said, there is a clear need to invest more in UHC. I mean, despite our push, not too many countries have achieved. In fact, very few countries have achieved universal healthcare, and we continue as part of our work that we are doing on social protection to call for increased investment in health and investment in universal healthcare. COVID-19, but Rob, I do think COVID-19 was a wake-up call. Even before that, but after that, we are seeing a number of countries really wanting, there is an increased political will. I'm a bit more sanguine about the will of countries now to really strengthen their health system. So I do think we need to seize that opportunity and steer
this commitment in the right direction. Second, I do think even in countries which have implemented universal healthcare, what's coming out is perhaps the preventive and health promotion angle has not been that strong. We really are stressing on a life course approach to addressing NCDs. And that is something that is going to be critical. And as I'm going to move and talk about community participation, one thing is very clear that the term multi-sectoral really has to be given real meaning. We keep talking about multi-sectoral involvement, but I'm not too sure. We need to involve them in the discussion. We need to get them in. If we are going to implement health promotion, if we are going to talk about more healthy diets, if we are going to talk about increased physical activity, if we are going to talk about tobacco control, if we are going to talk about other risk factor addressing which lies in the other sectors, addressing the determinants, we need the other sectors in. And I'm not too sure we're doing the right work. And organizations like mine can play a much stronger role, and we are trying to play a much stronger role in that respect. Coming to community engagement, I think it is very critical. And we saw some really wonderful, important points being made here. Now, obviously, health systems, one, I relate it in the context of older persons. Our health systems, even when they are, even in countries where they're supposed to be functioning well, expect the clients to come to them. We need health systems to reach out to older persons where they are, rather than expecting older persons to come to them. And I think the community can play a very important role in providing this linkage. I would also like to put in the community, there's a difference between there's a much broader implication. I mean, when you talk of community involvement, it's just beyond them just filling in the gaps in service provision. That's one very small part. I think the bigger issue is community involvement in the whole spectrum, and Kira Kopp did mention this, and she talked about community being involved in the design, being involved also as part of providing input on the accountability of the system, whether it's really serving its purpose or not. We also need to engage. I mean, we hear the word community involvement being used, but community is not the same everywhere. It's not something that also develops spontaneously. The sense, the way the communities are structured may differ from country to country, from a rural to an urban setting. I think that some things may work very well in a pilot format, but if you need to upscale it, it needs really considered policy and programmatic inputs right from the beginning. And so I do think there are certain areas where it needs extensive capacity development. I think we ought to be looking at community involvement right from the inception, from the planning of health systems to really in all aspects of the health system. Yes, they do have a role in filling up the gap as a complement to the functioning of the health system. Sometimes I do not see community as totally replacing the formal health system, but as a complement and a supplement. At some point, people are talking about paying volunteers. I think that's important for paying them part of the cost that they may suffer. But then once you start paying them on par with health workers, they become part of the system. Are they really part of the community, or they're part of the paid health system? So that is something that we need to see. And I think it's important that we identify clear roles for the community. There are several good practices that we can learn from. But as mentioned by Dr. Koot, I would say that sometimes we tend to depend on the community for too much. I think being structured, knowing what they can do, and having a very focused expectation from them would help them deliver whatever we want better. And I think to have too many expectations from them would really, really not work. And I would again like to stress that they cannot replace formal health.
Some really, really important points there, Srinivas. Thank you. I'm going to just ask Nani Paz if she would also like to make a comment. Nani Paz, you, with the older people you work with, your activism shapes policies. Can you tell us what you need from government and from the international community to achieve better health for older people in the Philippines?
Actually, what we need right now is more financing for our community-based programs, because right now we don't have a support from the government. Actually, the government is more focused on their programs regarding primary health care. But at this time, they don't have enough funding. So we have to resort to suggesting to them situations where the government can resource more funding for universal health care.
So certainly the finance side. And what advice, Nani Paz, would you offer to other activists and stakeholders who are wishing to influence their governments?
Yeah. Well, actually, right now, the government through DOH conduct consultation wherein we and the CSOs suggest funding for our sector, especially the older persons. In the Philippines, there are only 100 plus geriatric care doctors. So through the government, we want them to focus more on the making or giving scholarship to those students who will specialize in geriatric care.
Absolutely, to boost the training, very, very important.
Yeah.
Well, that's been a really fascinating set of inputs. And Srinivas said, health is everyone's business. And then we saw Jacqueline Wong come in the chat saying it was the business of an awful lot more people than just the people we've talked about so far. So I wonder, Jacqueline, if you're online, whether you would like to elaborate, whether you would like to flesh out the comment you made in the chat. We're just going to see if we can find you and unmute you. Oh, just there. Jacqueline.
Hello. Hello. Hello.
Yes, Jacqueline, we can hear you. Do you want to?
Sorry. In my opinion, it's all boils down to political will and how much allocation funding they give to health, because access it's not adequate, and most of the time, aging populations remain overlooked. As I said, governments need to look into a holistic approach to successful UHC on aging well, which means that it has to address education, health, food, social work, retirement, pensions, investments, care support, and so much more. And like I say, it's everybody's business. And, it's just not only the government as well, it's also private sector, it's individuals, it's policy makers, and it's also the people, to ensure that we live and age well. And in the end of the day, the government makes the policies, and it has to make it with listening to the people, what we need, fund it, invest wise, invest more, but we must be prudent. And we need governments to approve this, otherwise we may be able, we want to go, but we can't move if the government doesn't support us. Thank you.
Thank you. Yes. So Srinivas, I know you have to leave quite soon. Do you want to just put in a last comment?
No, I think this is a very important discussion, and I think it should be continued in terms of it has a very close link to this whole concept that you have of implementation of the decade of healthy aging. I think it's about time, and I'm going to focus a bit on the needs of older persons. It's about time that our health systems are structured to address around the needs of the main clients. And the second point that we made a calculation about and presented to our member states about the investment in healthy aging, and that is central to that is addressing NCDs, is the health dividend. We know that healthcare care costs are going to go up. And the first point that I want to make is population aging is an achievement that we have strived for. And it's not something that I would like to give it a far more positive connotation. And the second point is to talk about the fact that investing in NCDs is really going to reduce, NCD prevention is going to reduce the amount of healthcare expenditure that you're going to suffer in the future. And we are modeling that goes all around it. It makes economic sense. It makes sense from all sorts of dimensions. So thank you.
Very much. Thanks for your contribution today. So in the chat, we've had some questions coming in, one for Dr. Coate and one for Dr. Wang, but because they've disappeared off the screen, I can't see now what the questions are. So I don't know, Ken, if you've got a microphone or if you can help us with what the questions were for Dr. Coate and Dr. Wang.
Hi, so that's a very good point. Let's just see if I can scroll back up. For Dr. Coate, I think it's a very technical question, but it's really important in terms of understanding how do we implement some of these things. The question was about do we have existing standards or recommendations by which electronic medical records that have been successful in implementing universal healthcare? It's about understanding differences between implementing personal or patient-based electronic records. And perhaps let's just broaden that out a little bit to just reflecting a little bit on the digital experiences that we've had in implementing this kind of technology, how it's being used, what we've learned from that through the project.
Thank you. We have been experimenting with a technology called DHIS2, District Health Information System, originally developed in the University of Oslo and now already implemented in around 50 lower middle income countries. And they have also developed a system called DHIS2 Tracker that can be used locally and also by community groups. And we have been using that in Vietnam and Myanmar. And there it worked well, though, as I mentioned before, there are many issues with digital literacy. So you need, if you want volunteers and community groups to use it, you need really to help them understand it and use the tools and make the tools simple. We did just an evaluation of it in Vietnam. For example, the font size appeared to be an important issue for many of the older people without good reading glasses to be able to use digital tools. So there are some very simple things, and we are going to publish about these experiences. So hopefully we can share it. But what is very critical, if you use digital information system, the people who collect the data should also analyze the data, should see the data. So in this tool, there are dashboards, and there they can easily see how things are going, how many people come for screening, what are the risk factors, who is participating in all kinds of community activities. So if you introduce digital tools, it must not be just for the experts who later do analysis and scientific publications, but the users who actually collect the data should benefit from it. So that's the key for introducing digital tools, that the persons who collect the data should really benefit from it. And if you don't have that, they will stop using the tool afterwards. And the nice thing, we did a study in Cambodia where also the community groups of Help Age want to introduce it, and they were very enthusiastic about it, but they say the same thing as I'm now telling here. It should benefit us, and it should not benefit only the researchers.
Mm-hmm. Great, thank you. So there was also a question for Dr. Wang, and after that I'm going to ask Greg and Rob if they have any comments on what they've heard so far in this discussion. But first of all, Ken, do you have the question for Dr. Wang?
Unfortunately, Dr. Wang is not on with us at the moment, but there's another question that came through from Camilla, which probably be easier if I just read it out, and I'm going to just add kind of an additional take on that, because I think there's a part of this which we want to hear reflection on that perhaps Rob might be able to come in on as well. So Camilla's thought was, and question was about how do we convert community engagement in health and care into broad-based demand from the population for public financing and investment in health. So we've got that community engagement, but then how do we actually use that to get more of the public financing and investment that we've been hearing is missing and is needed? And it would be good to hear Nani Pas's experiences from the Philippines about engaging beyond the aging and older people's groups and networks and seeing how they've managed to link up with other stakeholders. But can I just then add in the reflection from Rob to that, which is we've been making lots of assumptions in this discussion about the importance, the significance of this focusing on these communities, on the health of older people in NCD prevention and management, but being very mindful that's not the priority necessarily in the international community in universal health coverage. And, you know, so your thoughts on kind of how do we bridge that gap? You know, how can we get the attention of policymakers who should be investing more in this, but maybe aren't? Thanks.
Yes, thank you very much, Ken. And it's really quite straightforward. Get political. I mean, these issues are more political than they are technical. And I think, you know, to have this sort of community action, community engagement, the way that you're going to get the public financing is by influencing the ministries of finance, but also, you know, state governments and heads of state as well. You know, this underfunding, which is, you know, common in the Philippines, and it's a phenomenon here as well. You know, the NHS is grossly underfunded. You know, we just sort of seen doctors striking, you know, about 100 yards up the road at UCH. These are political decisions that have been made by governments, and really, I sort of recommend people of all ages, sort of older people, younger people, you know, if they feel that their needs aren't being met in terms of healthcare allocations and how the health budget and health spend is split between prevention and curative and different age groups, one needs to get political and you know, I think sort of take it to the policymakers, obviously presenting the best evidence, and this is where all the research is extremely helpful and useful to show that this money will be well spent and will result in better health outcomes, but also as being smarter and presenting the economic benefits of doing these things, the societal benefits of doing it, but also the most blindingly, obviously, the political benefits. You know, this will make you popular. This will get you re-elected. You know, this is good democracy. And I think so often we tend to skirt around and not address that these things are massively political. And just a little pitch for our work at Chatham House. We work on the political economy of universal health reforms, and we've set up a commission very much to try and aim at a head of state level to encourage political leaders, just like we were hearing that, you know, now is a great opportunity to launch universal health reforms. So many of the world's great universal health systems have come out of previous periods of crisis, be that conflict or health emergencies. So now I think with things being so volatile and up in the air is the time for us to get much more active politically. And we at Chatham House would be absolutely delighted to work with you on that.
Thank you, Rob. So Nane Paz, it's political. What do you say?
Well, actually, yeah, it's true that it's political because most of the times we have to engage with legislators so that laws are passed. We do our priority right now is engaging with the legislators. So we visit them at their offices and we do rallies to let them know what we need. And one point also is creating awareness on the part of the community that what they need is creating awareness on the community to let the legislators know what they need.
Important work, really
Yeah.
important. And Greg, from your perspective, what's impactful for policymakers?
By
Yes, so I have another reflection maybe before going to your question, because I've seen in the chat someone mentioned that we should push certain way the public and private partnerships. And I think this is maybe something which we were missing, because there's a big demand of the investment in primary healthcare for NCDs or universal healthcare. And I'm afraid that only the public investment might be not sufficient for this. So would maybe incentivize the private sector to scale up the private investment in this area as well. So this would lead more to the sustainable development, supported by all the communities, also those which have also say in the development of the healthcare services. So I don't know whether someone would like to comment or reflect on this point.
Rob, how do public-private partnerships sit with you?
Well, I think recognizing that the key to universal healthcare, which is primarily public financing, I mean that's the best way to sort of get the healthy, wealthy, cross-subsidizing services for the sick and the poor. But when it actually comes to the inputs that go into the health system, manufacturing pharmaceuticals and computers and stuff like that, obviously the private sector will have a massive role in making the stuff. So I think the way that, that you recognize that the public sector is better at some things than other things. And Julio Frank very neatly sort of showed that when it comes to governance of the health system and the financing source for the health system, it should predominantly be public financing, undoubtedly. When it comes to service delivery, it's a sort of a toss-up, and when it comes to the manufacturing of inputs, it should be predominantly in the private sector. So I think that's a good way of looking at it, is the split between provision and financing, and then you sort of get a different picture, I think.
Thank you so much. And Dr. Wang, we have a question for you if you're back with us. Dr. Wang, we want to know, why is the health of older people becoming a higher priority in Vietnam? Do you know what has helped to push the health of older people higher up the political agenda? Okay, so we're going to go back to Greg, and we would like to ask you, Greg, about what you think is needed to make the research and evidence that we've been talking about today most impactful for policymakers.
Most impactful for policymakers. I mean, it has to be aligned also with in certain way with the feasibility of implementation of the certain evidence in the certain let's say policy environment. Is the policy ready for incorporating certain evidence coming from our research? That's also linked with this, what I said at the beginning of this session, that there has to be a reflection up front at the moment of the designing of certain actions, of certain research. Is there the timing and the momentum right for immediate impact on the policies? Whether this will lead to the certain improvement of the current say healthcare systems. So I think these are maybe the points which shouldn't be neglected in the design of the research, and that has an impact on the policy making.
To dig into that a bit further.
Well, I think that's right. Often, I don't know exactly the process of approving research. Often they look very much at the technical quality of research, but I think, and I don't know, maybe it should also be a question for GACD. How do you think that the research that you are all commissioning and the different research projects that you are financing, how does it trickle down to policy making and advice? Do you have a strategy on that, on how to translate all the research that you are commissioning into really changes in practice? Because that's the final goal of all research. And of course, we did hear from Vietnam, where the government is embracing the ISHCs and growing to 10,000 ISHCs. We are very happy that they are embracing that model and incorporating the work that we have done. The same in Indonesia, where the experiences are shared with government and changing the way they are doing practice. So we have small examples where it did work, luckily enough, because we were already looking at possibilities where we thought that government would take up our research. But maybe you have a strategy on that as GACD or as EU.
And Greg, I can see your hand, so we'll come to Margaret and then we'll come back to you, Greg.
Okay, thank you.
Yeah, it's a real challenge. I think we've spoken earlier about the importance of engaging with policymakers right from the start of the project. And that's something that at GACD we're really promoting and saying, rather than do your research and then come to the policymakers at the end with your evidence, actually engage them right from the start and work out what they need to know, what questions are they asking, what information do they need to inform their policy. I think when we so often do research and then disseminate our findings at the end, the policymakers are, they have lots of pressures, financial time, and they have different priorities. They may be interested in our findings, but they're not in a position to actually integrate that into their policy. So I think for us, one of the key things is that early engagement and really actively engaging with policymakers. We know that the most likely time you're going to get policy change is when the researchers and policymakers are working together as a team, really with the same priorities. We have projects where we have policymakers who engage and part of the research team. But I think we've talked about policy change, but your question also relates to that next step of implementation in practice at scale. And that is a big challenge. I think we may look at creating evidence that can then inform policy, but then can the country actually roll out that policy and implement it? What are the challenges that they're facing in that context? It is a big challenge, and I'm not sure I've really got a clear answer to that. But I think I would just say for us, the key thing is that kind of working closely, so that our researchers are working closely with policymakers and really engaging them, understanding where they're coming from, what their priorities are, understanding the context they're working in. Thank you.
Great, Margaret. No, that's really valuable. So I said we'd go to Greg because he had his hand up, and then we'll go to Rob. This is a really hot topic.
Yeah, so thank you very much. So I would only add to this what Margaret just said. Also, in the design of the call topics for the certain research, we should look rather for more impact-driven approach that simply obtaining the results like this. So it has to be a clear definition: who are the recipients, who are the target groups, for whom the certain outcomes of the project are designed. So, for example, whether these are the policymakers, these are the healthcare providers, or simply citizens, etc. So it's a very clear strategy going from the outcome of the project through the expected impacts, short-term impacts, long-term impacts. So, and this altogether has a bigger chance to be successful in integrated in the policy making. So, yeah.
And I think the importance of recognizing that policymakers are a very heterogeneous group, you know, that so it's not good enough just to persuade the Ministry of Health that this is a good idea. That's the easy bit, you know, just showing the health benefits. Often what you need is the public financing, and you need to present very strong evidence to ministries of finance, who are often not particularly interested in health and don't like spending money on health. So you've got to be pitching the economic benefits, the employment benefits, the likelihood that people pay taxes, really sort of try and get into their heads about what's motivating them, but also be going to the heads of state, the heads of government, to promote the societal and political benefits as well. So I think to bring all those policymakers along right from the start, and in fact, if anything, perhaps the most important thing, to find a political champion very early on, is often the best way to get these things, you know, through. And that might be a state governor or someone who's not in power at the moment, but trying to become head of state, something like that. So very much be thinking about a political strategy as you're undertaking the research.
Nane Paz, I think you and the older people you work with are very clever with your political strategies for influencing. So what do you find makes policymakers that you are meeting really listen and take on board what you're saying?
What we do most of the times is visit them at their offices. Then we prepare a program, or the advantages that we have to introduce to them, like the priorities on healthcare, and most of the times we have to find champions to work together for these policies. Champions among the legislators. Yeah.
Perfect. So I think Jacqueline Wong, you're an older person yourself, and you wanted to come back into the conversation. So Jacqueline, if you would like to rejoin us, we'd love to hear your comment.
Thank you, Margaret. I just want to stress and I told policymakers that by the end of this decade, there will be more people over 60 years old than there are of under 15. We need to know that the future are among us, and we need to invest in the future now. When you look at 60-year-old than 15-year-old, this will not be fiscally sustainable for the economy. Policymakers must know that healthy populations empowered by good healthcare interventions add value to society and the economy, which is important to them. So prioritizing healthcare system UHC responses and actions now will enhance the prospects of current, as well as we will see the returns of investment in future generations. As I said, a 5-year-old now will live to 100 next century. We are now with them. We need to look after them too, and to be as well as possible to live a long and healthy life. And this tells us that we need to invest in people for the future now again. You know, investments in education, we need to work more years, rethink financial security, recognize that life changes, you know, life transition is a feature and it's not a bug. You could be living well or you could be a caregiver. We must build social infrastructure, support transitions and life stages. You know, that's the saying that people plan and God laughs. You know, we need to look at potentials of science. It's amazing today. And again, improving health span, procedures for useful look and so much more is possible. The future is with us today. So we must look at UHC progress in health today for future generations. Thank you.
Thank you so much. Absolutely. Soon there will be more people over 60 than 15-year-olds. So this point about older people adding value to the community, to the economy, absolutely agree with you. So who would like to pick up from there? And while you're thinking about your next comment or question, I'm going to take the opportunity to point out that we have some excellent policy briefs based on the findings from the SUNI-SEA project. And the link is in the chat for you. You can see it there now. So do please look at those briefs. And once the chat has gone, you can still go to the website and find them there. They're full of really, really useful information. So how about Nane Paz telling us a little bit about the work on alternative budget initiative, helping the budget allocation to enable implementation of legislation. Is that something you could tell us a bit more about, Nane Paz?
Actually, alternative budget initiative is a network of CSOs that work with the government and find out what are the allocated budgets for the year. So most of the times we engage with the legislators or policymakers, and we submit budgets that has to be taken up during their sessions. So from there, that will be the basis of forming a policy, or what we call the, for example, for 2024, we have already met for the allocation of the Department of Health for to be submitted to the policy makers for approval of the president.
Thank you so much. So I'm scanning the room to see if there are any questions from the people here. Otherwise, I'd like to ask Greg and Rob and possibly Dr. Coate if they have a final remark before we move to the closer, which is going to be Margaret. So Greg, and then Rob, Dr. Coate, final remarks, and then we'll move to close.
So thank you. May I continue? Yeah. Do you hear me? Hello. Okay. So so thank you very much for these very interesting discussions. So I have one reflection after the statement of Dr. Srinivas. So it was very interesting point about the communities. Not all communities are the same. And also not every country has the same specificity in terms of the communities. So I think this is a very important thing. And yeah, in designing certain policies, of course, this should be also taken in account very, very much. And also from our side, if we are designing the research or especially implementation research, from the implementation research perspective, it's a very nice area of really looking at this all these aspects and putting certain things forward. So thank you very much.
Any final remarks to close?
Just that I'm an optimist, really, and I think that you know, we are very, very powerful in wanting more spent on health and sort of to live longer, healthier, happier lives. And I think that if you look at COVID-19, the case for universal health coverage has never been stronger. And I think, you know, leaders who obviously woefully neglected their universal health systems and perhaps undermined the COVID response. If you look at President Trump, President Bolsonaro, and today Boris Johnson, all being hounded out of office because of their inept COVID responses. I think that just shows how powerful we are. So I think we should grab this opportunity. And now is the time to be very much pushing for UHC reforms that truly do cover the entire populations, you know, sort of from, you know, older people right through to younger people as well. So, you know, we should grab this chance, really.
Now is the time. Dr. Coate.
Well, talking about healthcare financing, the failure of our project, we had intended to go with our results also to health insurers and tell them that they should shift their thinking from only paying for curative services also to preventive services. We didn't manage to do that because of all the delays of COVID, but that's still one of the follow-ups that we have to do. And talking about Rob's perspective also, that there should be public pressure also. Those insurers are more or less public organizations financed by our contributions. And they should invest more in early diagnosis and early treatment rather than in treating all the complications once people are in advanced stage. So maybe we can, with our cost-benefit analysis, show them that there's a benefit for them investing in earlier diagnosis and treatment, and hopefully that will also contribute to a change in the way primary healthcare is being financed.
Thank you so much. Nani Paz, do you want to give us a very final short word?
For me, we should concentrate on more advocacies for all the policies that we want the government to implement, and most of all on UHC. Thank you.
I think that's the note on which to thank you all very much indeed for your contributions. It's been a very rich discussion. I've learned a lot and I'm feeling really inspired as I hand over to Margaret to close the conference.
Thank you. Yes, I have the difficult job of pulling out some of the key takeaways from our discussions today. As Alison said, this has been a really informative and rich discussion. We've heard a range of voices from around the world, from starting off with the voices of the SUNI-SEA participants, and then finishing with the views of policymakers, funders, and others. We've heard examples of approaches that have been used, for example, the intergenerational self-help groups in Vietnam and Myanmar. We've heard about community engagement for NCD screening in Indonesia. We've heard about other examples of community participation in the Philippines and other global examples of social participation. So there's a lot of approaches that we've looked at. We've talked about the need for scaling up interventions, and ultimately these and other NCD interventions need to be scaled up and delivered through the national health systems, through primary healthcare systems, through community approaches. And in this way, we're really working towards achieving universal health coverage. It was really interesting to hear a lot more from the SUNI-SEA project and some of their learnings. And we looked at the 3 dimensions of scale up in what they've done in terms of increasing the package of services that are available at the community level and in primary healthcare clinics. They've looked at increasing coverage through reaching unreached populations, and also the importance of addressing quality of care and improving the capacity of health workers. So some of the themes that came up in the discussion, I think there was a lot around the burden that we put on community members and volunteers, and whether we're relying on them to deliver services. Some of the challenges around that, the need for more investment in health workers and health system strengthening. I think particularly when we think about these volunteer health workers, we talked a lot about the need for continuous capacity building, continuous support, not just giving them initial training and leaving them to it, but actually providing refresher training, building their skills in the different areas that they need in order to be able to do their work. Also building the capacity of the primary healthcare staff. So at the clinics, although they may be trained health workers, they still need capacity building around NCDs and the services they're providing. We talked about co-creation and encouraging ownership by community members, not just delivering something to them, but actually involving them in that design. Also the importance of involving national and also local authorities and having a favourable policy context for delivering these interventions, creating an enabling environment, participation and considering power dynamics. We've talked about the life course approach and the need to bring in different interventions and different strategies to address people at different levels and different ages and stages of life. We've also talked about the use of digital tools and some of the pros and cons around this. There was the example of the self-care app used in Myanmar. We've talked about the need to make sure that data that is collected is actually able to be seen and used by the people who are collecting it. It's not just for the researchers, but it's actually for them to be able to use in their communities. And we've had a really rich discussion and heard views from different stakeholders. We've talked about the need for multi-sectoral engagement. We may be quite good at engaging with the health sector, but how good are we at engaging with other sectors? We've talked about needing to engage early. With the funding, we've obviously at GACD, we are representing a number of funding organisations, but we've also talked about public funding being needed. There's need for funding for research, but there's also need for funding for implementation and scale up. We've talked about the need to invest more in funding of preventive services, and Dr. Coote's examples about the cost benefit, actually looking at if the major funding is going towards treatment, actually by funding the preventive services, we're going to reduce the costs of treatment. And then we've also just been talking about some of the challenges related to changing policy and practice. So for GACD, from our perspective, the next steps for us. So primary healthcare is really key in all that we do. Engaging communities, reaching those unreached populations. We launch funding calls for implementation research, and we have a funding call each year. The one we've most recently allocated is on the life course approach to NCD risk factors. And there's 23 new projects just started around the world looking at the life course approach. The next funding call that will be launched in the autumn this year is on integrated management of multimorbidity. And again, for this, primary healthcare, health system strengthening, community engagement will be key. So these are some of the priorities that we are really investing in with our funding agencies, looking at trying to really integrate, not looking at standalone NCDs, but looking at systems as a whole. Some of you may also be interested that we're planning to hold our annual scientific meeting in Hanoi, Vietnam this year. So it's been really interesting to hear some perspectives, particularly from the Ministry of Health and other representatives in Vietnam. And we may have the opportunity to connect in person. So yeah, I just wanted to end there really. And I want to leave us with one final comment that struck me from the NCD Alliance video, actually, that people must come first. In all that we do, people must come first. It's all about, we're talking about linking people, communities and primary healthcare. We've talked about policies and universal health coverage, but the key takeaway from me is it's all about people and communities, and people must come first. Thank you.
Well, that's all for today, folks. Thank you very, very much to all of you who've participated. Been great to have you with us. Wonderful discussion, fantastic wrap up. We're done. And a thank you to all the technical support up at the back from the venue here. Thank you guys and girls. You've done a great job getting us through various glitches. We're grateful. Thank you to everybody who's helped make this work.